Thanks very much, and thank you, Wally, for that really wonderful and warm welcome to country. Really appreciate everything you've done for keeping us safe and nurturing the university community. It does feel in many ways that protecting us is so fitting for a field epidemiology training program. Thank you. And to everybody here, on behalf of the university, I also want to acknowledge the traditional owners of our land, the Ngunnawal and the Ngambri people, and also the land on which all of you are residing as we meet together today. I want to pay my respects to elders past and present, and acknowledge and pay respects to any Indigenous people who are with us in this meeting. Quite simply, the MAE is a jewel in the crown for the Australian National University. It embodies the vision of ANU as the intellectual powerhouse for nation building and to guide the nation through its greatest challenges, as was espoused in legislation for the university in 1946 in post-war Australia, and which is just as relevant 75 years later. The MAE has helped make the ANU the great global university that it is. It's done it by attracting fantastic students. It's done it by preparing leaders who've gone on to really make a difference. It's shifted paradigms of knowledge and approaches to teaching and learning and to public health practice. And it's contributed to the nation's well-being. And it could be no better evidence of that than the last 2 years and all the work that so many of you have contributed directly to in keeping Australia safe, and for which we all owe you a debt of gratitude. Why is the MAE so distinctive? I think there are a number of reasons to me. The first is obviously as an FETP program, it's different to a coursework program. And as a clinician, the learning by doing approach is both familiar and highly valued to me. I know the enormous difference that it makes to what you learn and how you learn it, and then how you subsequently apply it to actually roll your sleeves up and get your hands dirty and be part of practice while you're learning. Secondly, the MAE is so well connected into a fantastic international network through TEFINET and through ongoing direct association into TEFINET and its governance and board, and through all the community around the world that has embraced field epidemiology and taken it to its dizzying heights. The MAE program at ANU has been very much at the table throughout that journey. Thirdly, and perhaps most importantly, it's the people that have gone through the program. From the vision of Bob Douglas and others 30 years ago, to all of you and all of the extraordinary people that have been both teachers and students of the MAE over that 30 years. We're so proud of every one of you as staff and as alumni, what you've gone on to achieve and what you've gone on to create as both a discipline of field epidemiology, as a body of experienced people on whom the nation and the world can draw, and on a community of practice that contributes to teaching the next generation and to continuing the work of field epidemiology. I can think of no more admirable group of people on the planet than the group that are gathering here today. And of course, what makes it distinctive too is its impact. And as I mentioned before, in the midst of a global pandemic, Australia has done extraordinarily well. It's done extraordinarily well because of the public health practice. Maybe sometimes with the help of and sometimes with the hindrance of all the other things that are going on around. But it's the public health practitioners that have done the lion's share of the work that have kept us safe as a nation and in the good position that we are on now. And I again say that the nation owes you as a community a debt of gratitude for that. The university is absolutely committed to the future success of the program. And we see the 30th year anniversary as a great opportunity for celebration, as a wonderful time to take stock and reflect on what's been achieved in 30 years, and to think about the future. For if the global pandemic has done nothing else, it's made us really sharpen our thinking and our vision for what is needed in the world going ahead from 2021. ANU wants to make sure that we're still charting new waters, leading the cause, getting the best people on board, and ultimately having a positive impact on the world through knowledge for the nation and knowledge for a better world. MAE program, I salute you. I, as Dean, am really grateful that you've contributed so much and you're part of this community. And I'm really looking forward to today, to delving deep into some of the achievements and the history and to getting some discussion going about what that future vision is for the program and how it might evolve. So thank you very much, everybody, and back to you guys, and I look forward to being with you for the day.
Thank you, Russell, for that warm welcome. So the MAE program is celebrating 30 years of training public health leaders. Our graduates have played crucial roles in health security around the world. Now we'll hear from several of the graduates from the program. First up, I'd like to welcome Professor Raina McIntyre, Head of the Biosecurity Program at the Kirby Institute at UNSW. Thank you, Raina.
Thanks, Emma. And it's such a pleasure to be here and to see so many familiar faces. You know, Tony Stewart and I shared an office my first year as an MAE in the Department of Health Victoria. So he was in the first cohort. So it's great there's people from the first cohort here. Firstly, I'd like to acknowledge the traditional owners of the land where I am, which is the Gadigal people of the Eora Nation, and pay my respects to elders past and present and emerging leaders. So lessons from the pandemic, you know, first of all, I think field epidemiology matters. It's kind of an invisible discipline, but it has been critical for the pandemic. People who've had that kind of shoe leather epidemiology training, who understand the principles of outbreak control. For me, the MAE was really groundbreaking. It was a completely different way of learning to what I'd been used to up to that point. You know, I was a registrar at Prince Alfred Hospital, and Bob Douglas came and met me in the cafeteria one day to interview me for the MAE. I was kind of interested in epidemiology. I saw the ad and I decided to apply. And it was really the most revolutionary thing I did in my career. It changed my career direction. I was planning on being a cardiologist, but everything I did in the MAE was infectious disease outbreaks, and it changed my direction. And it's really a wonderful program, and it's so good to see the 30-year celebration happening today. So field epidemiology matters. The second thing is that public health is invisible. You know, we saw the defunding of the MAE program when the FERP funding was cut back in several years ago now, and there was really no understanding of the importance of the program. At the beginning of the pandemic, we saw really good planning for surge capacity for ICUs and hospitals, but no understanding that you also needed surge capacity for things like contact tracing and case finding. And this is what caught Victoria out during the second wave. You know, Victoria really had a decimated health system which had been stripped bare over 2 decades of successive governments. I worked there even after my MAE at the Royal Melbourne in the mid-1990s, and that's kind of the period when it started to be stripped away. And that's fine during the good times. You know, a bare bones system can function in the good times, but it becomes exposed in a pandemic. And what happened last year in the second wave was that the contact tracing ability, they just couldn't keep up with the contact tracing. One case might have 10 to 20 contacts. So as cases rise exponentially, the contacts rise even more exponentially. And if you can't find them and quarantine them, then you lose control of the epidemic. And there's a tipping point that comes, which New South Wales has clearly already exceeded, where you can't keep up manually with contact tracing, and you need to either use digital methods or revert to more draconian measures to try and control the epidemic. And yet, case finding and contact tracing are the single two most influential things in epidemic control. If you lose the ability to do either, you lose epidemic control. And that's exactly what we saw in Europe and in the US early in the pandemic last year. The next lesson is that epidemic control requires non-pharmaceutical intervention. And those of us who work in public health know that there's heavy investment in diagnostics and in drugs and vaccines, but much less investment in the kind of public health measures that need to be used. So that includes things like testing and tracing, but also social distancing, movement restriction, and face masks. And when epidemic control is lost, a lockdown is the last resort and works by just stopping people having contact with each other, so stopping the opportunity for further transmission. So public health measures by nature are draconian, which is why it matters how they are implemented and the kind of messaging that goes with them, which brings me to the next lesson, which is about culture, leadership, and healthcare. So you might recall that towards the end of 2019, the Global Health Security Index was launched. And it's not a bad index, really. It has most of the important factors in there, but probably missed culture, leadership, and healthcare. So according to the Global Health Security Index, the US was ranked number 1 in pandemic preparedness, and countries like Vietnam and Samoa were ranked really low on the list. And yet what we saw in early 2020 was that countries like Samoa just closed their borders and remained COVID-free, and countries like Vietnam controlled the pandemic very well, but we saw complete loss of control in the US and in multiple European countries. So I think those three factors. Culture is really about whether the culture is civic-minded and accepting of public health orders, or more individualistic. So I think the US is probably the most extreme example of a highly individualistic culture. Leadership then matters, because if you've got the combination of a highly individualistic culture and bad leadership, which we saw in the US last year, that's disastrous. And universal healthcare matters, because if you've got to pay $100 to get a COVID test, which was the case in the US, in many parts of the country last year, you're not going to get tested, right? Because you can't afford it. So access to healthcare and, you know, the things we take for granted in Australia is a major factor. So I think the Global Health Security Index could be revised to add those three things into it. The next lesson is that the health system is the weakest point in a pandemic. And we've seen this lesson learnt over and over again, and we're probably in the middle of this lesson being learnt all over again in New South Wales. But that countries that have demanded freedom for people have come to a grinding halt when the health system collapses, when bodies start piling up in refrigerator trucks, and when people have to be refused care because of their age or pre-existing conditions. And in some cases, in Italy and Spain last year, people aged over 40 were unable to get to ICU beds. And that's the result of the surge in exponential growth, that your hospital system and your health system gets the capacity is exceeded, and then your level of care starts to fall. So you don't get the same level of care in intensive care. You may not get intensive care at all. And also your case fatality rate starts to go through the roof. When you look at the differences in case fatality rate, the countries that had the highest case fatality rates last year were ones that did not have high levels of ICU beds per head of population and ran out of capacity. So when you can't ventilate someone, that's when your deaths start to really fly through the roof. And the next lesson was about false narratives. So we've seen false narratives abound during the pandemic, from, it's not a pandemic to it's not transmissible between people to it's a choice between the economy and epidemic control, which is probably one of the biggest falsehoods that's been peddled during the pandemic. Most of the economic studies, and just objectively looking at what's happened to the GDP in different countries who've controlled the disease in different ways, shows that the economy does better when you control the epidemic. And the other is about airborne transmission, which has been denied really up to about July this year in parts of Australia, which resulted in a lot of hygiene theatre, scrubbing of surfaces and washing of hands, when really what matters is the air you breathe. This virus is spread through the air you breathe. If you don't ventilate an indoor space adequately, doesn't matter if someone who's infected has left, you'll still be at risk walking in there and breathing that air. There's been other false narratives about herd immunity through natural infection, and about children, there not being any consequences for the infection of children. And the UK is a good example of the extreme of that, whereas other countries have moved to, including Australia, have moved to protect children with vaccination as soon as feasible. And finally, I think I'll end up with the lesson around senior people having the courage to speak truth to power. In countries with authoritarian, populist or autocratic governments, being a sycophant brings great rewards. But speaking truth to power and speaking out about what actually is in the best interests of public health, of the health of populations, can come with a high personal cost. And I don't recommend it for junior people or people who are mid-career, because they actually do risk their careers. I know of people who have lost their jobs or who have been suspended from their jobs in the hospital system for daring to ask for an N95 respirator when they were told to treat COVID patients with a surgical mask. So there is a high price being paid by people at all levels that is not apparent to everybody. But I think when you're at a senior level, a good example, for example, is the discussion about boosters, right? I've noticed if I mention third dose boosters, often it gets shouted down with the call for equity in other countries, right? Global equity. Now, Australia has enough vaccine to provide doses to our neighbours. We've got much more than we need for our whole population, so equity shouldn't be a problem. And yet, we had a vaccination rate of 7% in Wilcannia and close to 40% in affluent suburbs in Sydney at the time that the outbreak started in Wilcannia. So please don't talk to me about equity in other countries until we've fixed the equity in our own country. So I really encourage people to speak truth to power if you're in a position to do so, because that actually can make a difference to the health of whole populations. Thank you.
Thanks very much, Raina. We have time for a couple of questions. Is there anyone who'd like to ask questions? Please either unmute yourself or use the chat function.
Hello, it's Martin speaking. Hi, Raina. That was really fantastic. Thank you for giving a presentation. It's great to have people like you come and talk to us. So my name is Martin Kirkham from the ANU. I'm just interested, I noticed there's been quite a bit of commentary about whether we'll reach herd immunity with COVID vaccine like we will for measles. And I noticed that you said you think we will. And I'm interested, and there's a lot of misinformation out there. It's really hard to work out what's true and what's not. I'd be interested in your comments on that, and if you think we might be able to get to an elimination status at some point like we do with measles.
Yeah, I think it's possible. It's definitely achievable, but it will depend on policy choices. So to achieve that, you have to choose vaccines with the highest efficacy. And if you need boosters to maintain that efficacy, then you keep using the boosters. I don't think it's possible with lower efficacy vaccines because you have to actually prevent transmission. We know that some of the vaccines do prevent transmission. The situation we've got now is not the situation we'll have next year or the year after that. The vaccine pipeline is dynamic. There's new changes all the time. We will have vaccines, the vaccines we have now are matched to the Wuhan strain, which pretty much died out in March. And then we had the D614G through most of last year and then other variants since then. So it doesn't protect against the Delta variant. None of the vaccines protect as well against the Delta variant. But that's a temporary situation. We will have matched vaccines and that'll drive the herd immunity threshold down and drive the efficacy up. So really it depends on policy choices. I think the countries to watch will be Israel. I don't think the US will get there because they have a major problem with anti-vaccination, so they probably won't reach the levels of coverage needed. They may, but I think Israel's the country to watch to see what happens because they've been very responsive and agile to changing evidence. As soon as the evidence came that the Pfizer was waning, they stepped on with the third dose booster, and I think they'll do the same when there's match vaccines, so we watch and see. But for Australia, it really depends on what... I think we have to try. You have to aspire, I'm not for just aspiring for the lowest possible goal. The lowest possible goal is, we'll stop you from dying. I think we should try for better than that. We should try to prevent transmission.
Thank you. We have time for 2 more questions. So I see Tony and then Stephen Lambert.
Hi, Raina. Great talk. Thanks very much. You mentioned false narratives and you also mentioned about the masks and airborne spread. Why do you think there was so much reluctance early on, not just here, but globally, to acknowledge that a simple intervention like wearing masks would be useful in a respiratory virus? And what can we do to sort of move past that mindset in future outbreaks? What sort of evidence or what change do we need to make to be better prepared so that we don't have a repeat of that the next time we have a similar problem?
I mean, I've worked in the field of masks for more than a decade, so I know the background, and it's just too detailed to go into for a short answer, but I think the reason was more around ideology and the composition of infection prevention control committees, which, the discipline of infection control arises from patient safety, so it's not ever had a focus on health worker safety but we had a lot of messaging at the beginning of, do not wear a mask. It actually might harm your health. We've still got people on the WHO IPC committee saying you'll get acne if you wear a mask. So, I think the problem's been there for a long time, for probably 2 decades, definitely since SARS-1, since 2003. But the reason nothing's happened is that the stakes have not been as high, right? If someone gets flu on the ward because they were told to wear a surgical mask, they're probably not going to die from it. But in this case, the stakes are much higher. People have died. The case fatality rate's higher, the infection fatality rate's higher. It's actually, caused devastation around the world. So I think that actually has forced the changes that have already occurred and will hopefully result in more permanent changes. But, there was a commission into SARS in Toronto, which, where basically there was a tale of 2 cities. There was Vancouver and Toronto, both of which had their first SARS epidemic at the same time in 2003. Vancouver used the precautionary principle. They gave all their health workers a respirator and they didn't have an outbreak. Nobody died. Toronto said, no, it's not airborne, it's just droplets, you can wear a surgical mask, you'll be fine. And they had a big outbreak and healthcare workers died. So there was a commission into that, like a royal commission. And the commissioner, that's where sort of the use of the precautionary principle in healthcare has really resonated, came out saying, it's not about who's right or who's wrong in the debate about droplets, but you have to use a precautionary principle, which is that you don't await scientific certainty. You do everything you can to prevent harm for healthcare workers, but none of those lessons were learnt this time around. None.
And final question from Stephen Lambert.
Thanks, Emma. Really enjoyed that talk, Raina. Thank you very much for sharing those lessons with us. One of the first things you said is if you lose ability to case find and contact trace, you lose control of the epidemic. And one of the amazing things about this, our response to this pandemic, I think, has been the upscaling of laboratory testing to identify cases. But I think where perhaps we haven't quite done so well is improvement in digital infrastructure to allow real-time contact with people who might be contacts. So there does seem to be a delay there. How do you think we best manage preparation for the next pandemic? Do we need a CDC with a national digital capacity to contact people very quickly? Do we leave it to states and territories but try and harmonise what they do? Or is there another solution that we haven't yet thought of? Thanks.
So thanks for the question, Stephen. I remember sitting around in Aileen Plant's apartment on her carpet with Kathy Mead and Aileen and Rob Hall talking about a CDC. You know, this is a conversation that's been going on for decades, and I don't think it's ever going to be resolved. You know, Australia's done pretty well without a CDC, and the US did abysmally badly with a CDC. So I think some of those other factors really come into it, and the decision to close the border is probably the single most influential factor for Australia. But definitely that, you know, Australia did very well with the testing. We saw Australia get on top of that really quickly, as opposed to the US, where, you know, even now it's hard to get a test. It's really shocking, you know, that the testing space in the US, and they just couldn't get on top of the testing through the most of last year. It was just shocking. It was shocking. Nothing more shocking than seeing the most technologically advanced country in the world unable to do that. So I agree. In terms of digital tracing, I think that is the answer, to move to the mass scale that you need to when an epidemic gets really big. Otherwise, you have to use a lockdown, right? Otherwise, there's no other way to control it. And Asian countries have been doing it. So China started using digital tracing during Wuhan. They were having about, I think, 4,000 cases a day at the peak, something like that. So not far off where New South Wales is heading. But they soon lost the ability to do manual contact tracing, and so they switched to digital. The biggest problem in Western countries is the privacy issue, because to go for the systems that don't require opt-in, you have to overcome some privacy barriers. But I think our public health legislation at state level can deal with that. You know, that's what it's there for. Use it, use it. And just, you should be able to just, if you've got a smartphone, you should be able to just walk through a door and it just captures the information without you having to do anything. It's possible,
Fantastic. Thanks for that. Please join me in thanking Professor McIntyre for that presentation. Now we'll move on to Dr. Tambri Hauser from the School of Medicine and Public Health at the University of Newcastle. Thank you, Tambri.
Thanks, Emma. So I've been asked to share a bit more of a personal journey, my personal MAE journey today. But before I start, I want to acknowledge the Ngunnawal and Ngambri people and pay respects to their elders past, present and emerging, and also particularly acknowledge the contributions of our First Nations MAE scholars and alumni. So I titled my talk The Long Way Round, as that reflects the way that I came to the MAE program. So I started out as a paediatric nurse many, many years ago. And even as a student nurse, I was looking for patterns and links between cases. I remember working in theatre and we had 4 children present with brain tumours. So I was looking through their files to see where they lived or if there was any exposure that could be common across them. I realise now how difficult it is to draw such links between pathologies like that and environmental exposures. I went to work with MSF, and while working with MSF, we had a group of skinny children present at our clinic, and we then subsequently conducted an assessment in the area and identified a need for additional resources in what became a massive nutritional crisis in the area. So these were things that I was not trained to do in my nursing. And it wasn't until later, when I was doing a Masters of Public Health and Tropical Medicine at James Cook University, that I heard about this thing called epidemiology. And I was like, that's it. That's how my mind works. That's exactly what I want to do. And David Durheim from Hunter, New England, Population Health, was up teaching in the course, and he mentioned this program offered by ANU, the MAE program, Field Epidemiology Training Program. So I applied in 2005. I was shortlisted, made it to the final cut, but didn't get across the line. So when I rang Mohammed Patel, who was actually the program director at the time, and asked him what I needed to get through, he was very gracious and said that my application was very strong, but that year there were a number of applicants that had PhDs. So he recommended I went and got some research experience, but advised me I didn't have to go as far as getting a PhD to apply next time. He encouraged me to apply the next year. However, I became pregnant with my second child, so the MAE was once again on hold for me. We moved countries again. I had another child. I think all the children prevented me getting back to the MAE program. But what I did do is, in need of getting my brain cells firing with enough Wiggles and Thomas the Tank Engine, I did enrol for my PhD. So many years later, when we had moved to New Delhi and I was working with MSF in India, the country director indicated that they wanted to advertise for an epidemiologist. So I thought, well, here's my chance. So I contacted the medical director in Amsterdam and said, can I do my MAE with MSF while working as an epidemiologist in India? And he was open to the idea, but wanted to have a chat with the program. So I reached out to Martin Kirk, who was the program director at the time, and floated the idea with him. And I hear later from Martin that he was extremely sceptical of the idea, but he was supportive, and he took me on as an MAE scholar with MSF, even though my field supervisor was my partner, which also for him seemed to have the alarm bells ringing. But 10 years later, after my initial application, I did end up doing the MAE with MSF in India. I felt I was extremely fortunate to do this way. I'm still with my partner, so we survived the supervisory relationship. I think he took a bit of a hands-off approach and let me do my thing. But needless to say, my MAE was my PhD on steroids. So it was a very full-on couple of years. I had the privilege of working on some fantastic programs. I did a large population-based cross-sectional study looking at mental health in the Kashmir Valley in India, which was 10 times the size of my PhD project, and that was my EPI project for my MAE. For my data analysis project, we did the cultural adaptation and validation of the psychometric screening tools that we used for the survey. I was very fortunate to go to Nigeria and evaluate the MSF Nigerian Emergency Response Unit surveillance system, and had the opportunity to investigate an outbreak of neonatal sepsis in Pakistan with an MSF-run clinic, which turned out to be a case of antibiotic resistance rather than an outbreak itself. So I learned an immense amount of in a very short period of time during my MAE journey. And after finishing the MAE, I found myself as a staff member on the program. We were finishing up with MSF in India, and Martin encouraged me to apply for a role on the program. So I spent the next 4 years as a faculty member, and within the first year, the leadership baton was handed to me to run the program as everybody slowly left one by one, and I found myself the sole trader on the MAE. And I really want to shout out to Fiona and Laura, who were an amazing support during that time, helping me navigate the bureaucracy and processes at the university, which there are many of. I then had the joy of welcoming the team, Ross, Ben, Emma and Pip and Hayley, to the program over the next few months. And I think for my time on the MAE program, I was introduced to the most phenomenal network of people, both nationally, regionally and internationally. So I'd spent most of my career overseas. So coming back to Australia, I hadn't developed a strong local network within the country, and I found that very rapidly with the MAE, I developed very strong connections throughout the country and the region. So through this network, I worked on a number of collaborative projects and have really seen the value of this network during the pandemic, sharing of resources, knowledge and experiences between EPIs right across the globe from every corner of the earth. It's really been quite phenomenal to be part of such a network. So I've had people talk to me about applying for the MAE who I think should be teaching on the program when I hear about their experience. And I say, why do you want to do the program when you could actually be teaching on it? And they say it's for the network. It's recognised that the Global Field Epidemiology Network is a really, really strong and valuable network. So I left the program at the end of last year to start a consultancy company and work more closely with the team at Hunter New England on strengthening field epi capacity in the Pacific. The international setting is really where my heart is and where I feel most at home. And one thing I was reflecting on with this talk, Emma, was thinking through, what the MAE has given to me. And I think, the technical skills, obviously, to be a solid field epidemiologist is the obvious one. But it's also enabled me to develop really strong collaborations nationally, regionally and globally, of which, I'm benefiting from today in many aspects of my work. And also to develop some great friendships with phenomenal people from right across the globe, which has really been an immense privilege. So I wanted to finish off my talk today with a video of the people that I have the privilege of working with today who are having a phenomenal impact in their country. And this is due to my MAE journey. So even though I did it the long way round, I got there in the end, and I feel really fortunate to be able to work with the people that I work with now. So Toby, if you're able to play the video, that would be fantastic. Thank you.
We work hard to keep our communities safe and healthy.
We work to strengthen service delivery so people receive high quality care.
We work to create and strengthen surveillance systems that detect public health threats.
We collect and analyze data for evidence-based decision making.
And we respond.
We go where we have to go and do what we have to do
to make sure we leave no one behind.
We vaccinate people, test and treat people,
and protect people from the impacts of public health emergencies.
We work with communities to educate and empower people
to protect themselves and their families' health.
We've been on the front line of this pandemic response from day one.
And we're still here, and we will continue to serve our communities.
We are field epidemiologists.
Thanks so much, Tambry. We have time for a couple of questions. Raise your hand or unmute yourself if you'd like to ask Tambry a question. Okay, we've just got a couple of thank yous in the chat box there, Tambry. Thanks so much for your presentation and sharing your video for your work that you're doing in Papua New Guinea. Thanks very much.
Thanks, Emma.
Okay, so next up, the next presentation, we celebrate the First Nations MAE alumni. This is a recorded presentation, which is fortunate as many of the people in this presentation are currently involved in the COVID-19 response in New South Wales and cannot be here today. So in this presentation, we'll hear from Dr. Jill Guthrie and Dr. Jocelyn Jones from the 1998 cohort, Dr. Brett Shannon from the 2010 cohort, Bobby Marr and Roxy Jones from the 2017 cohort, and Dr. Tamara Riley from the 2018 cohort. And a special thanks to Dr. Jill Guthrie, who both provides her reflections on the MAE and also interviewed the other speakers in this presentation. So Toby, could you start the video?
My name's Jill Guthrie and I'm a Wiradjuri person from Western New South Wales. I was in the inaugural Indigenous cohort of the MAE back in 1998 and 99, so that's now 23 years ago. My placement at the time was at the National Centre for HIV Epidemiology and Research. NCHECA was the acronym for that.
My name's Bobby Ma. I'm a Yamatji woman from Western Australia, and my ties are really to the East Kimberley, Pilbara regions and the Noongar Nations. So I did the MAE in the 2017/18 cohort, and my placement was actually in the Commonwealth Department of Prime Minister and Cabinet in the Indigenous Affairs Group.
My name's Tamara Riley. I'm a Wiradjuri woman. My family's from Western New South Wales, and I did the MAE in 2018-2019. I was placed at the ANU within NSEF, the National Centre for Epidemiology and Population Health, in the Aboriginal and Torres Strait Islander Health Program.
My name's Roxy. I'm a Palo woman, and I was part of Bobby's cohort, so 2017 and 2018. My placement was at the ANU in NSEF in the Aboriginal and Torres Strait Islander Health Program as well.
My name's Jocelyn Jones. I'm a Noongar Whadjuk woman from the Perth area. I have family connections to the Balladong region. That's where I grew up. So that's where I find my most recent, relevant ties to me today. My grandparents are Whadjuk, and they were born on the Swan River or the Derby Yerrigan in Perth area. I've also got connections to the Pelgu group in the Pilbara of WA, up near Marble Bar and Roban. That's where my mother's ancestry lies. So I'm like a lot of Aboriginal people. We're mixed, and we've got lots of connections throughout country, which I think is it gives us that real rich connection, doesn't it, to different parts of the land. And you feel when you go to different countries, you feel that spiritual strength, and it's just so welcoming. I really like that, and I really like that I do have this ancestry, throughout WA. I was in the first cohort with Jill, and I think there was 8 of us. Yep. And I can remember at the time I had my youngest son, and I think he was about two and a half, or yes, 2 when we started, and he was very much part of the MAE with me, and he certainly had a lot of grandmas looking after him at different times, and it was really nice, because I guess as the first MAE we were the trial, so like it was a little cohesive group, wasn't it? And, yes. And we all bonded really nicely, and we all shared the load with each other, which I thought was really amazing.
What are the key lessons that you took away from the MAE?
There were so many. I can't say how much I learned throughout my MAE, both professionally and personally. I think I had come from a nursing background, so when I joined the MAE, I left clinical work, and so I was coming into something completely new. Had never really done stats before or anything like that, so. The MAE was a challenge, but it was great. What I learnt from my projects was so much about community engagement and the importance of listening and working with community. That was definitely the biggest lesson that I learnt, and I'm just grateful that I had that opportunity.
Yeah, I think I feel the same about the lessons. And as I said, it does feel like a long time ago, but I just think, I just kind of marvel at what little I knew. And then, what I did end up kind of knowing at the end of those 2 years. And it did have to do with the fact that my cohort, and that inaugural cohort was a cohort of 8 Indigenous, scholars, and from all over Australia. So just developing that network as well, which was very a fantastic opportunity. What advice would you give for current MAEs or, prospective MAEs who might be considering applying for the MAE?
I tend to promote the MAE to certainly some of my Aboriginal and Torres Strait Islander peers. And I mean, I put it to them really as a way of, challenging themselves and thinking more about it's an opportunity to actually kind of bring in more sort of Aboriginal and Torres Strait Islander kind of worldviews and perspectives into, a Western kind of research paradigm. And I think that it just really helps to empower you as a person, but also you can be part of facilitating that empowerment with communities and community organisations.
I think my advice for people considering applying for the MAE would be to do it. I know I considered it for a while before I did it. I think that it can be maybe a bit intimidating applying for the MAE, thinking is it for me? Does it fit with what I do and what I want to do? And I think that a good thing about the MAE is it's quite flexible to different experiences, to different backgrounds. And really, in a lot of ways, you can make it like what you need to make it for your career. So I think that it's quite adaptable. And the other thing I would just say is if you do the MAE and opportunities come up, when you can take them, because that was some of my biggest learning curves, was taking the opportunities that put me out of my comfort zone, but I learnt a lot along the way.
I think it's all been said beautifully by you other ladies. I just think it's a great opportunity to challenge yourself. It gives you the skills to be able to work wherever you desire. And not only do we need Aboriginal people in the Aboriginal community working, with Aboriginal people and data, we also need to have, like Bobby said, Aboriginal people working in lots of other mainstream areas as well, because we need to, being able to reflect on the MAE. I think that's one of the things we've been able to do is reflect on how we have the ability to make changes in the way mainstream does business with Aboriginal communities. So I reckon just, challenge yourself, give yourself the confidence, it's supportive, and, you've got a skill that you can use for the rest of your life. And it will take you in all sorts of directions.
Hi, my name is Shannon. I was part of the 2010 MAE cohort. I completed my MAE with the Institute for Urban Indigenous Health and the Queensland Public Health Unit. Over the 2 years of the program, I completed a number of projects, including a data analysis in Queensland on vaccine timeliness, looking at differences in provider type and Indigenous status, an evaluation of Queensland's pneumococcal surveillance system. I worked on a number of outbreaks, but my favourite project was my main thesis, which looked at barriers and enablers to health assessments in Aboriginal medical services. This project was part of a number of reforms we were doing at the time, looking to increase the uptake in health assessments, and it was quite successful. Since 2009 to 2017, we actually saw over a 3,000% increase in health assessment uptake in Southeast Queensland Aboriginal medical services. These projects and the program in whole, it really gave me exposure to a wide range of clinical programs, health promotion initiatives, epidemiological methods, and even health finance models. I think the important thing about the program was that it allowed me to use those and apply epidemiological methods to population health data to really drive clinical changes in Aboriginal medical services. The program also spurred me to then undertake medicine at the University of Queensland, and now I work as an advanced registrar in occupational and environmental medicine. And I'm also conducting a PhD in occupational and environmental health at the University of Illinois in Chicago, which is where I'm filming this from today. My PhD is looking at occupational exposures and how they drive health inequities both in Australia and overseas. Whenever I talk to Indigenous students who want a career in public health, I always talk to them about trying to develop an extensive toolkit that you can use to undertake different types of research. And that's the beauty of the MAE program. It allows you to really develop a diverse toolkit, but also tailor it to your individual needs and areas you want to work in. Be it GIS software, be it sampling methods, be it longitudinal data analysis, environmental health, you really get to choose how you want to tailor the program. And that's the beauty of this program.
Okay, thank you to all that contributed to that video and for Toby for editing. So please join me in thanking those presenters for today. Okay, our next presentation, I'd like to welcome Dr. Stephanie Davis, who is the Deputy Chief Medical Officer at the Australian Government Department of Health, and who is also from the 2008 MAE cohort. Thank you, Steph. I'll hand over to you now. You're on mute.
Sorry, Emma. I'm just trying to share my screen right now. Give me a sec.
That's fine. We can hear you loud and clear now.
Excellent. Okay. All right, probably should have done this earlier. Apparently I have to update my computer to share my screen, so that's probably not going to work. All right, well, look, my presentation was really a bunch of photographs, to be quite honest, so I'm not sure it's going to actually add very much to me talking it through, but there were some nice photos in there for anyone, so I apologise for the lack of visuals. Look, like Tambry, I was asked to give I suppose, a bit of a personal presentation around what I learnt from the MAE and sort of how it's influenced my public health journey. Before I start that, I'd just like to acknowledge that I'm speaking today from the traditional custodians of the land in which I am is the Ngunnawal and Ngambri people. I'd like to pay my respects to those people. And it's particularly pertinent, I think, because an interest in Aboriginal health was really one of the things which brought me into the MAE, and one of the things I suppose I'm most proud of to contributing through supervision of some Aboriginal and Torres Strait Islander students. So I feel a bit disingenuous with the name of this talk. So it's called Chance, Bias, Confounding and Truth, what I've learned about each of these since the MAE. And really the reason I called it this was because I got an email saying I needed to give the title of my presentation and within the next 5 minutes or so. And so I was kind of scratching around trying to work out what I'd call it. And I thought about my 3 favourite MAE quotes. So one is courtesy of Muhammad Patel: if it can't be put in a 2x2 table, it's not worth knowing. Okay, the other one was the answer is always it depends. And the other one was you can answer every question in the MAE with chance, bias, confounding or truth. And in the end, I thought that the third one was probably the best one to try and structure a talk around. Okay, so in terms of my MAE, so I was in the 2008-2009 cohort along with a bunch of people online today, and particularly Emma. I was placed at Darwin CDC, which was fantastic. I mean, one of the reasons I went into the MAE was because I did my initial junior doctor years in Darwin. And what I found very frustrating working as a junior doctor was that you'd see the same people cycling in and out of hospital all the time with the same conditions. And I'm quite lazy by nature, and I thought there's got to be an easier way of doing this than treating them when they get here. Like, surely we can do something before they get here. So it's kind of how I ended up looking at public health, and then the MAE was just such a great way of studying that. So my supervisors for my MAE were Vicky Krause and Scott Cameron, who were fantastic. But generally my MAE was actually pretty unspectacular, and I'm saying this for anyone who's feeling perhaps like they're not succeeding in their MAE, any of the scholars at the moment, as well as they think their cohort was. I was constantly comparing myself to the rest of my cohort. I didn't do any exciting outbreak investigations. I did a particularly unspectacular one of salmonella at a restaurant that found absolutely nothing. I didn't publish a paper. I had the late peer review draft, which then, for a variety of life circumstances, never went any further than being submitted and getting revisions on. don't do that. It's not a good idea. I didn't get to go overseas. I was literally the only person in my cohort who didn't get to go overseas for either a conference or a placement. And I didn't do any kind of complex analysis. Like, I was pretty much descriptive and data cleaning. So that was my MAE. And like I said, I wasn't feeling terribly good about my success as a public health professional at the end of it. But what I really did get, and I didn't realise this until later, was that I got a really broad range of experience, and particularly on the ground public health experience. I got really, really solid skills in data manipulation, which I think over time I've learned is probably actually just as important or even more important sometimes than the complex data analyses that people like to get hung up on, because there's more mistakes. I think probably most people would agree there's far more mistakes made through not collecting the right data or through not looking at it properly or not looking at it at all than in doing the wrong kind of regression analysis. I helped out with the last pandemic, the 2009 swine flu pandemic. I made some really fantastic friends, and I'm very disappointed I can't show the incredibly daggy photo of us all on our post-MAE camping trip. And I had some very, very, very good lessons learned for a number of projects that didn't go anywhere because I wasn't organised or didn't think them through, or various other reasons. So in terms of, and that sort of moves me on to thinking about chance. So in one of the projects I did was I set up the Northern Territory surveillance system for World Youth Day. So many of you may be aware that World Youth Day is a Catholic gathering that happens, I think every 4 to 5 years. I can't remember now. And everyone comes together, and the Pope arrives, and people sit in all different parts of the country, and they all come together in a central location for a week. And it's a really joyous, big mass gathering celebration. So the deal that I did with my MAE supervisor with Vicky, that she'd let me go to Sydney for a week to help out New South Wales Health with the World Youth Day surveillance if I'd set up the Northern Territory surveillance system for World Youth Day pilgrims. And my surveillance system was very comprehensive and very sensitive, and it picked up absolutely nothing. And I think that's because absolutely nothing happened. But I still managed to make a chapter out of it. And I still got to go to Sydney, and that was fantastic. And then as a result of that, the next year I was working with WHO in Geneva. I'll talk about that in a moment. But because of my experience in World Youth Day, I got deployed for the 2010 FIFA World Cup to South Africa. And I was situated in the South African Department of Health for 4 months, and was really helped set up their surveillance system for the World Cup. And that's one of the real highlights of my public health career still. Because it's a surveillance system which really brought together a whole range of things across the Department of Health. They've reactivated it on several occasions, including for the funeral of the late, great Nelson Mandela. So it's had real legacy and impact. And so I suppose what I really learned from that, just reflecting on the last talk, I think someone mentioned about taking every opportunity. So even if your experience is not particularly publishable, even if it's not particularly spectacular at the time, those learnings can just be so important later on. So in terms of bias, so with regards to bias, well, the reason I said I was in South Africa, I got deployed from Geneva. So the reason I got deployed from Geneva was because Angela Marianos, who was in the very first MAE cohort, I'm not sure if she's on the line today, was working in Geneva at the time. And as part of the swine flu pandemic, she needed surge capacity. And so myself and the other Steph in my cohort, the other Steph Williams, which caused no end of confusion, both got hired. I think they might have been thinking they were hiring just one of us, but anyway, we both got there. And I did surveillance with there for about a year, apart from going to South Africa. Now it was rumour surveillance, so it wasn't particularly spectacular, but it was just such an interesting experience to learn how an organisation works like that at that level. And I think I learned a lot of sort of organisational skills through that. After I finished up in Geneva, I moved down to Port Hedland. There's no direct flights from Geneva to Port Hedland, interestingly, but I finished off my public health training there. I actually got that job on merit, not through the MAE network, which might be the only job I've got not through the MAE network. But that was a really fantastic experience again, but I drew so much in that on my MAE work. So I did a lot of the surveillance there'd been a lot of staff turnover and there wasn't much going on. So I did a lot of training around, again, just looking at data, doing pivot tables, training up the nurses, training up the Aboriginal and Torres Strait Islander health workers. And it again, just drawing on those lessons that I'd learned during the MAE to try and bring some of those processes and systems into place, which is incredibly rewarding. So anyway, back to Bias. The next job I got entirely through my MAE connections, which was when Martin offered me a job teaching on the MAE program in 2011. I just moved down to Canberra, was looking at a period of unemployment, but anyway, I ended up at ANU teaching on the MAE, and I was there for about the next sort of 7 years all up, with a few short breaks, and ended up convening the program for a couple of years. So when I came on board, it was during it was just after the FERP funding had run out, so it was a big sort of developing a new funding model, which was a very challenging time, but also a really exciting time. We thought the program was going to end initially, and then we got it going again. So that was really amazing. We had some fantastic students. It was great to see their experiences, and it was just so wonderful seeing some of them fly. Some of the ones who came in with a real lack of confidence and exited feeling good and confident and just doing and contributing so much to that work. And during that time, I mean, having taught that many people, of course, strengthens your network enormously. In fact, I just literally just before this presentation, I got a text from a friend who's not an MAE alumni, but someone had tweeted her the program for today, and she asked if my presentation was called, and I quote, MAE alum, Australia's cabal of people I have taught. And the reason she asked that was because we were working together at the Department of Health last year, and every time we had a meeting with everyone, I'd say, oh, I taught that person, or I worked with them. So I think that's the other big thing we all take away from the MAE is those extremely strong networks. Okay, so moving on to confounding. So January 2020, again, I was speaking to Emma on the phone. I think it was a social call at that point, and we're talking about these rumours we'd heard about this strange thing coming out of Wuhan. And I remember Emma, Emma, I don't know if you remember this conversation, but I think you're saying, do you think this is going to be big? And I said, I reckon it's going to be bigger than swine flu. So I was right about that. Okay, I think my next comment was, well, we won't be able to control it because the only way you can control a pandemic is if people close borders, and governments will never do that. So I was completely wrong about that one. So anyway, a few weeks later, I was actually on a plane to Christmas Island with the first lot of the Wuhan evacuees. Again, this was a recommendation through Pip Binns, another MAE alumni who I think is on the call today. And again, it was really using a lot of the skills I'd learnt from my MAE around surveillance, setting up, a database, and all those basic things around monitoring the health of those evacuees as they came through. So finally, truth. We've gone through chance, bias, confounding, we're on to truth. So I had a very funny meme there which said I was an epidemiologist before it was cool to be an epidemiologist. So again, I apologise, I can't share with that one to you. But I think just reflecting, I think there's a lot of lessons I think we can all learn from COVID that I think will be reverberating for many, many years to come. I think around the discussions around equity and how COVID has perhaps brought some of those to the forefront. I think the sort of, epidemiology now, everyone knows what an epidemiologist is, which is pretty amazing. But I think there's also been a lot of learnings around perhaps how we communicate epidemiology and how we communicate uncertainty when people are frightened and they do actually want certainty. And I think we're probably still trying to communicate what is the truth, but how when the truth is not clear, I suppose, what is the truth might be that we just don't know. And I think that we'll be grappling with those lessons for a long time and probably thinking about how the MAE will look after that. So the truth is still out there. I think we've got many, many challenges ahead for our profession. I don't think this pandemic is over yet by a long way. But a few more things about the truth. I think the evidence will always matter. Collecting and looking at the data, that lesson that I learned during my MAE still remains really key. The good friends and the colleagues that you meet through the MAE will continue to sustain you. And it's really been an honour and a privilege being involved in the MAE since I very first started as a student. So thanks very much.
Thanks very much, Steph, for the presentation. Have we got any questions? We have time for a couple of questions for Steph. Please either unmute yourself or type a question into the chat.
Hi, Steph. It's Bridget.
Hey, Bridget.
Here. How are you? I'd just be keen to hear how you're finding your role at the Commonwealth now.
So I think it's just a bit of background. So I was seconded to the Commonwealth in March last year, and I was working in the primary care area as a senior medical advisor, and then I've moved into a deputy chief medical officer role about 3 or 4 months ago. So I think it's and as you probably all know, the chief medical officer is Paul Kelly, who was the director of the MAE when I was a student. So again, networks going through the years. So I think it's a really interesting time to be part of the Commonwealth. I think there's been a lot of change, perhaps, in how structures have operated through the pandemic. Maybe not as much change sometimes as there's needed to be. For me personally, it's a huge learning experience. It's a real honour, but it's a huge learning experience. And perhaps what I'm really learning is around that intersection of epidemiology and public health versus what's viable and how to influence things, I suppose. So when are we taking a purely public health evidence data-based approach, and when are we thinking about other considerations as well? So it's a steep learning curve, I think, is the main thing I'd say.
Richard and Steph. A question from Hayley.
Steph, it's Hayley. I just had a question about whether there were any points in your career trajectory where you might have had to make a choice. I mean, it sounds like certainly the MAE opens up certain opportunities and there were some sort of nice steps through your career pathway, but did you ever have to make a really difficult choice about taking one job or another, or think about changing the path you're on?
Thanks, Hayley. It's a really interesting question. So I think the main thing is I've never had any kind of a plan around my career. I'm astounded at the position I've ended up in at the moment. I mean, I think one big thing for me, which I didn't mention in the talk, is I actually went back and did general practice after a few years ago, and that was because I missed patient contact. And so that was quite a big impulse, because I was already a public health physician and I was quite well established in public health, and I went back and did a clinical training program, which was quite a big deal for a range of reasons. But I held on to my public health through that, so I certainly wasn't shutting that door there. But I mean, and that's been enormously beneficial for me, both as a public health doctor and as a person, to have a clinical and a non-clinical arm. So I probably haven't had any really, I think there's been times when I've really wished I could be involved in things in terms of difficult choices. So when during the 2014 Ebola outbreak in West Africa, I desperately wanted to go, and I had a 3-month-old baby at home. So that was obviously a choice not to go in that situation. So I probably wouldn't say I probably wouldn't say I've ever had a, sort of sliding doors moment, Hayley. It's more because I've always had, my priorities have always been around doing interesting stuff and then looking after my family, or hopefully looking after my family first and doing interesting stuff. But I think, I've probably also never really had a distinct plan. So I've tended to flip from one thing to another, which interestingly is a criticism you sometimes hear of MAEs generally, is this sort of flitting between things. And I don't know if it's because there are always so many interesting things to get involved in, or maybe the 4 projects make us more prone to doing these things. I don't know. I'm not sure if that answers your question, Hayley, but it's probably the best I can do, I think.
Thanks for the question, Hayley. And we have a final question from Tony Stewart.
Thanks. It's more of a reflection than a question. Steph, thanks for the talk. I just liked a couple of things that you said there, like you never had a plan and, flitting between jobs. I really think, the thing about what we do is that you have to be able to pivot. You have to say, I'm working on this, but suddenly this is more important, and I need to be able to adapt to that. And when those things happen or an opportunity comes up, it's like a quote about, good fortune favours the prepared mind. If you're ready to do that, if you've got the training and you've got the mentality, and at times your family situation allows it, at other times it doesn't. But it really is the hallmark of being a field epidemiologist that you will, reassess and reprioritise. And I think that, what you described there is really an ideal of, what we aim to do as field epidemiologists. So thank you.
Thanks, Tony. And I think the other thing is that flitting between things, like I've had a million jobs, it feels like, that it also going back to my point about everything you learn from. So everything you do, you bring your skills into the next position. Like in the job I'm doing now, it's high level strategy and policy, but I'm still looking at data and I'm still able to, talking to people about how to improve data systems on the ground because I have that baseline experience. And I think, again, every job you do, you build on and bring that experience with you. So while it may make your CV extremely long and make you potentially look a bit like you're not going to stay in a job for that long, it also, you just having a breadth of experience brings a huge range of strength to any position.
All right. Thanks so much, Tony, for the question, and thanks, Steph, for your talk today. I'll move on to the next presenter. So I'd like to welcome Associate Professor Linda Selby, who's from the School of Public Health at University of Queensland, and is from the 1994 MAE cohort. So over to you, Linda.
Thank you very, very much for this opportunity. I feel quite humbled, actually, given the amazing people who've done the MAE program, both now and so to be asked to also talk a bit about my journey, which is what I'm hoping to do now. So first of all, I'd also like to acknowledge that I'm on the country. I'm on the country of Yagara and Turrbal people and pay respect to their ongoing leadership and custodianship of the land and their elders past, present and emerging, and recognise their contributions to Australian and global society. So I thought I'd just give a bit of a thing about my career journey, just to put it in perspective, I guess. So I initially did medicine. Well, I started doing zoology at university, grew up in Darwin. In spite of having two parents doctors, really didn't want to do medicine. But like my sister, we drifted in, me from zoology and Christine from computer science and maths. But I really wanted to do medicine because I wanted to do research into cancer. So unsurprisingly, I did my PhD with Ian Fraser on HPV cancer. And then I did a postdoc at the NIH and I did in Washington, DC. And when I went over there, I thought that I was going to my dream job and that Washington, DC would be boring. But in fact, for me, it was the complete opposite. I found what was happening in Washington, DC far more fascinating than what was going on in the laboratory. And at that time, DC was predominantly African-American, I think about 80%, and then Latino, a very small proportion of white people and a lot of poverty. And I guess it kind of really opened up my eyes in spite of growing up in Darwin and being, interacting with a lot of people who are affected by racism. It took me to go overseas to kind of see that, I guess. And so I got involved in a lot of activities around racism. I moved to a community where, in a black community with a lot of poverty and drug dealing and so on, which was a wonderful opportunity. So I decided I wanted to do public health, but I didn't really know how to get there until Tony Capon, who some of you may know, sent me a letter that included a newspaper advertisement for the MAE program. Not really knowing even what epidemiology was, I applied for it and was fortunate to get there. So I left DC in the middle of a snowstorm, went to Canberra and started the MAE program based at Queensland Health. So I was lucky to be able to go back to Brisbane. So after the MAE, and I'll talk a bit more about that, but I'll just follow on from that. I was fortunate enough to be in a time when Queensland was just trying to build up some public health capacity. And so I was asked to apply for the role of Director of Communicable Diseases Branch with really no bureaucracy experience or anything. So I did that. Took a stint out to do some polio eradication work and was then asked to lead integrating strategy and performance across Queensland Health, which was an interesting experience. And then became Executive Director of Population Health Queensland, but getting more and more frustrated about not having the time to be an activist. I took on the role of CEO of Greenpeace Australia Pacific, then followed my heart to Perth at Kirkham University, and I had the opportunity to do a couple of go-on placements. Moved to UQ to support my parents who subsequently died, and looking forward to a retirement where I get to be a full-time activist and probably get arrested a few more times. So a bit about my MAE journey. My big focus initially was on hepatitis C, and casting minds back to 1994, it was only very recently that the infection had been detected, even though it was an old infection. I did a number of epidemiological studies, which I've listed there. But I was also the go-to person for Hep C. And so I got probably about 3 or 4 phone calls from people affected by Hep C at the time, and there was very little information we had at the time. So I decided to start a support group, corral a few people who rang me to kind of get it going, and together we put together a helpline and ultimately the Hepatitis C Council of Queensland. And one of those people who called was a person called Lee Strawn, who very intelligent, remarkable man who I ended up in a relationship with and married. So Hep C brought me my husband. Sadly, he ended up dying of hepatitis C later on. But that was the hepatitis C journey. And I guess for me, again, reinforcing my experience in Washington, DC, was that these infections often are just something that's affecting people because of a whole range of other factors. And the human side, you can't really separate from the infection and the epidemiology. And then in September, Queensland Health at that time had very limited, as I said, public health capacity. I worked very closely with John Sheridan, and it was basically John and I in terms of epi or medical capacity in the public health area. And he got a call from the intensive care unit at Royal Brisbane Hospital saying that there was a horse trainer, in intensive care, and there were also a lot of horses that were sick. So anyway, we went out to Hendra, to the address we were given, and this was the site that we saw, and there was actually blood dripping all over the road. And here we were kind of investigating maybe this infection where we didn't really know what it was, and a whole crowd of people standing around. It was pretty scary. So I got to do lots of site visits, walked around the neighbourhood talking to people, collecting blood. I participated in huge numbers of teleconferences with experts that Aileen Plant and John McKenzie set up. That was a real privilege and learning experience. Participated in a whole lot of Queensland level meetings almost every day. Couriered samples, did whatever I could in that case. And we were fortunate really that it turned out to be not terribly infectious between people. But the big focus really, and it was a bit of an eye-opener to me, was the races and the impact of this on the horse racing industry. And I went to meetings almost every day chaired by Bob Gibbs, who was a racing minister. Would you believe Queensland had a racing minister? And that was the huge focus, really, in terms of the media and interest, was about horses and racing. So ultimately, as you probably know, there were 2 cases, one who died and the other who recovered fully. And I think about 10 horses died directly from Hendra, but the others that were infected were euthanized, which reminds me of one of those meetings with Bob Gibbs when the decision was made by DPAI to euthanize the recovered horses. And Bob Gibbs actually said, this is a racing minister, he said, well, what about the strapper, who was the person who had recovered? You know, it was just one of those interesting moments where you feel like, wow. Anyway, the rest is history. I'm sure you know that there had been an outbreak in the Pike prior to that, but only detected the following year. But some of the interesting things for me, particularly as an environmentalist, was the link with flying foxes and then subsequent understanding about how that, you know, the environmental change really was what brought flying foxes and humans and horses together in order to spread this virus. And also, as I mentioned earlier, with the blood and everything, this whole thing, I think that Hendra really, at least for Australia, was a time when people really started to understand when working with animals, you do actually have to take care. So, like many have said, the MAE changed my life. I learned an enormous amount. I had this enormous privilege of investigating the first known outbreak of an emerging infectious disease. I met my husband, married in the program, made lots of friendships. And I think probably more important to me was my long-standing interest in blood-borne viruses and STIs that stem from that. And, you know, the interest in the human side of that. And it launched my next third career at that stage, becoming a bureaucrat. And within 8 months of finishing the MAE, I was appointed as Director of Communicable Diseases. And, you know, it was really something completely new to me. So it was a tremendously steep learning curve. Had to learn a lot about leadership, a lot about managing politics, which I've never done particularly well, I have to say. I just find it hard to bite my tongue. Lots of experiences with the media, lots of frustration about, you know, not really, which I'm sure others feel who work in government, of both dealing with the politics, but also this challenges in actually getting things done, but sufficiently to get, you know, some wins to keep me going. Well, at a time when I felt like I had enough, I was able to go and spend a year working in Uttar Pradesh and 3 months prior to that in Nepal on polio eradication, which was a great experience and a lot to learn. I got to learn a bit about change management in organisations, had to put up with a lot of restructures. But I think the thing that really kept me going was the sense of the big picture, the frustration of working in government and all the constraints, but knowing this is where you can often really have the most impact. But then, as I mentioned, you know, again, climate change was really what kind of took me away from bureaucracy. I just felt like I couldn't continue to be working very long hours in a bureaucracy when there's this other major challenge facing the world. So lessons learned, many of them, but I think, you know, we've got tremendous technical capacity, but I think that almost all of us learn that that's the easy bit and that it's the people stuff that's hard, whether it's the people stuff within the organisation you work in or whether it's the people stuff in terms of the politics or in terms of the population. And having to build and learn and develop those people skills, I think for me was really, you know, while I appreciate having the technical, it's the people stuff that I think we just have to deal with. And I remember Raina mentioned that earlier. The fact, because of that, that we need multidisciplinary teams for almost every public health issue. And often I found, working in Queensland Health, that in outbreaks and so on, it was a technical team, often environmental health and infectious diseases, missing out the sort of health promotion people who are often really critical as well. I've learned about the value of social science, and I bow to social science scientists all the time and how critical their work is. needing to think about taking a step back in terms of leadership too. Like I had to learn, I guess India was one of the first, well, not one of the first, but India was a real wake-up call in terms of needing to learn a bit of humility and supporting others to lead and recognising that we don't know everything. And I think that particularly goes, you know, as a white middle-class woman, that for us to really change society, we actually have to take a step back and support people who aren't white and middle-class to take the lead. And the urgent need to address inequalities within Australia and globally, and you know, COVID's really pointing that out, but of course we know it's not just COVID. And finally, I'd like to leave if Professor Gruen is still listening, that we cannot ignore the climate crisis and the massive environmental destruction that leads to that. So I would encourage the MAE program to try and kind of build that in, I guess, to the program, because everybody, we're all going to have to deal with it, even me, and I'm 60. And finally, I just want to acknowledge none of our journeys are done on our own. And mine certainly wasn't. And there are people who, in my career, but also my personal life, who enabled me to do the things that I wanted to do. But I wanted to especially mention Aileen Plant and how pivotal she was in my career, but also, of course, all her achievements in public health. So, yeah, I thank you, Aileen, with my heart. Thank you very much.
Thanks, Linda, for sharing your MAE journey with us. We have time for a couple of questions. Tony, your hand is still raised. Is that from...
Yeah, no, it's a good question. Yeah. Linda, thanks for that. It was just such a lovely demonstration of a typical career in field epidemiology, and thanks for the tribute to Aileen at the end. She's very special. Your last point there, I just wanted to pick your brains on that about the climate crisis. What do you see as the best way that the MAE program could contribute to that?
Well, I think that's probably, you know, we are going to need to have really strong surveillance, probably in areas that we don't have so well now. So I think developing that kind of capacity, which of course is what MAE does really well, but making sure that people that students and supervisors and stuff are aware of it. So I guess it's about sort of being aware that there's this overall threat that's going to be in a whole lot of different ways. So it's that preparedness, I guess. And I think, you know, we're well trained to be prepared for the unexpected, but I think with the climate crisis, we can kind of expect we can expect the unexpected to the level that we haven't had to do before. And so it's about having that awareness and all the potential ways that the climate crisis can hit, so that we're kind of, our MAE scholars and others are more prepared, if you know what I mean. I hope that's clear. I mean, the bushfires was one big example, like nobody was prepared for fires to that extent, and for the smoke harm and things to be prepared as that extent. And people were caught out, like we didn't really have good advice on smoke. We probably didn't have the surveillance systems that we could have had to look at smoke-related harms, to try and learn more about, to inform us in the future. So it's that sort of stuff.
Thanks, Tony, and thanks, Linda, for your response. We have time for one more question.
Emma, it's Pip here. Hi. Thanks, Linda. That was great. And I just wanted to maybe, it's not a question, actually more making a point in relation to your last comment about the bushfires and how Faye Johnson, an ex-MAE, was actually really key in that. So I think, you know, she's demonstrated how the MAE has contributed to development through the climate space as well.
Yeah, thanks, Pip. I'm really glad you mentioned FAE. That is a good point, and it does give us those kind of broader skills. I just think that we're going to need many, many FAEs in the future, so
yeah,
I'm sure that the program kind of covers that off.
Exactly. Thank you. Great talk.
Good point, Pip, and thanks so much. Thanks, Linda, for your presentation today. Okay, we'll move on to the final presentation. So Professor Martin Kirk was to present with myself and Dr. Vanada Jointopa, but he had a conflict, so I'll be presenting his slides today. And so, just 1 minute, I'll share my screen. We wanted to talk about the MAE program and how the MAE has contributed to work in the region. So, and given that we're talking about the region, it's important for us to stop and pay tribute to Professor Mohammed Patel, who partnered with many countries in the region to develop and strengthen field epidemiology training programs, or FETPs. He worked as MAE program staff for a couple of decades, starting from 1991 when the program started. And during that time assisted countries to establish FETPs in India, China, Malaysia, Vietnam, and the Pacific. One of the many things that Mohammed did was to work with other FETPs to establish TEPINET. So this is a global association for field epidemiology training programs, and Mohammed was the first chair of TEPINET. And he, in that role, he worked with TEPINET to improve the quality and consistency of training within these programs. Mohammed considered it vital that all training programs had an equal voice. So as I mentioned before, TEPINET, or Training Programs in Epidemiology and Public Health Interventions Network, formed in 1997 with support from US CDC and WHO. And since then, 3 of the chairs have been Australians. So as I said before, Mohammed Patel, but also Paul Kelly and Martin Kirk. Now there are 75 FETPs around the world across 100 countries, including 6 regional networks. And the mission of TEPINET is to develop, connect and mobilise the global field epidemiology workforce to strengthen health systems and advance health security. In our region, so the Western Pacific and Southeast Asia region, our regional network is SafetyNet. It's a non-profit organisation funded through US CDC. And it works with 14 FETPs in the Western Pacific region and 10 in the Southeast Asian region. And it arranges meetings with all of the directors of these FETPs in these regions, and is currently in the process of selecting representatives for the TEPINET board. SafetyNet has a capacity building role in terms of delivering train-the-trainer programs, and is looking to extend the network to veterinary field epidemiology training programs. So for any MAE scholar, one of the highlights is to have your abstract accepted in one of either the bi-regional or global TEPINET conferences. And this is a real opportunity for MAE scholars to meet with FETP trainees from around the world. And this is a photo from a regional conference hosted in Siem Reap in Cambodia in 2016, organised by SafetyNet. Another initiative in the region that MAE scholars participate in is the Western Pacific Regional Office Field Epidemiology Fellowship Program, which started in 2006. And this basically consists of at least 6 weeks placement in the regional office in the health emergencies team, where the scholars get to learn and undertake event-based surveillance, risk assessment and information management in emergencies. So over the years, many Australian MAE scholars have participated in this program, including myself, and some have even returned to work at WHO, and some are even still there. Okay, and now I'd like to talk about the ASEAN Australia Health Security Fellowship Program. This is funded by the Indo-Pacific Centre for Health Security. And it basically provides scholarships for ASEAN citizens or residents to undertake the MAE program with a field placement in their home country. So there's sort of two main end of program outcomes, the first of which is around strengthened human resource capacity through producing MAE graduates in these countries, but also through the work that these ASEAN fellows undertake through their MAE projects contributes to improved access to and use of evidence for disease threats, and also improves surveillance systems. So we had our first cohort in 2019 with an ASEAN fellow from Laos and Cambodia. In 2020, we had 5 ASEAN fellows from Laos, Myanmar and Vietnam. In 2021, we couldn't proceed with recruitment due to uncertainty with the COVID-19 pandemic, but this year we've commenced recruitment for the 2022 cohort, and we hope to have up to 6 fellows commence in 2022. So to date, we found that the ASEAN fellows have, through their MAE projects, have had a big impact in terms of contributing to strengthen health security in their countries. So most of the graduates, the ASEAN fellows were contributed to investigations of outbreaks of COVID-19 in their countries, as well as either implemented or evaluated COVID-19 surveillance systems. They do, of course, other projects outside of COVID-19, such as malaria surveillance or spatial analyses of malaria. We also encourage the ASEAN fellows to teach field epidemiology within their field placement organisations or within the shorter field epidemiology training programs in their countries. And we do also encourage the fellows to publish their work and present at conferences. So now I will hand over to Dr. Fanada Duanpopa, who recently completed the MAE and will provide her reflections. Fanada?
Hello, can you hear me?
Yes.
I'm not sure if you can see me on the screen because I couldn't see myself.
No, we can't see you, but we can hear you quite clearly. Thank you.
Okay, because I tried to turn on the video, but I don't know why it doesn't work. Yeah, I apologize for that you can't see my face. So good morning, I'm Vanida. I was on 2019 MAE cohort and I did my placement at the National Center for Laboratory and Epidemiology in Laos, PDR. So it's been a great honor for being able to share my MAE experience with you. Thank you very much. I will talk about my MAE projects. Next slide, please. My MAE projects were relating to vaccine preventable diseases and COVID-19 pandemic. So my outbreak investigation project was on a measles outbreak in a remote mountainous area in Saisomboon province. And my surveillance project was on a pilot phase of establishment of congenital rubella syndrome surveillance in children less than 1 year old. My third project was on laboratory findings of the first 1,000 cases of suspect COVID-19 cases. And lastly, I did a first few case and contact investigation of COVID-19 for my epidemiology project. Next slide, please. Throughout my MAE, I have found teamwork, trust, and open communication to be the key for my success. And I have also learned and be quite proficient at research, scientific writing, professional skills, and teaching and training skills. At the moment, I'm a pediatrician and lecturer at the Pediatric Infectious Disease Mahosot Hospital and the University of Health Science. So my plan to contribute to the field epidemiology are to use apply research, epidemiology surveillance in hospital settings, and in pediatric infectious disease. In particular, I'm interested in tropical medicine and vaccine preventable diseases. So that's all for my experience. If you have any further questions, please ask. Thank you.
Thanks very much, Vanita. And that's the end of the presentation. I will now see if there's any questions.
I don't want to be the one asking the questions all the time. I feel like that annoying person at the front of the room who's always got their hand up. Thanks again. That was another great presentation. I guess this is a broader question for each of you. And I think Pip and Tambri might also have an opinion on this. In addition to the countries that are in the ASEAN group there, what's the potential to look at our support to our nearer neighbours, so PNG, Timor-Leste, Pacific Islands, and is that already something that has been examined, or is it something we need to look into further?
There are a range of initiatives. So Tambri could talk about her work in PNG, but Sam, did you want to talk about some of the work in the Pacific?
Sure. Hi everybody. I'm Sam Gahoon. I work on the MAE program on the ASEAN side. So at the moment, the ASEAN program is we're purely have been recruiting scholars from ASEAN priority countries. However, based on the Mohammed and the strong background he's had through the Fiji National University developing their data for decision-making program and both certificates and graduate program through FNU in applied epidemiology. We are working with the Secretariat of the Pacific Community and Fiji National University through PACI-VIP, a DFAT funded initiative through the last round of APIDAR and PIDP grants to work on sort of strengthening supervision and mentoring, doing train the trainer, undertaking scoping exercises for individual country priorities around field epidemiology training. So there's, with SPC, there's rolling out that program, which they've had to rapidly go online with because of not being able to travel. There's a number of countries that have been involved in, just in the last year to 18 months training new students, and then we're assisting them with supervision and mentoring and sort of building that capacity in a community of practice. And we hope that that will also involve work with Safety Net through the ASEAN program. As Emma mentioned earlier, they're quite keen for us to help support them with that initiative, which is a real need and bonus for the ASEAN program to be able to support a community of practice. And Emma has been running a series of workshops sort of every 3 months around field supervision for EPs. As well as that, Martin and I work, and Ben Polkingham work in Timor. And I think around essentially malnutrition, but we've just received a large grant for 5 years' work that will look at food safety and food security, increasing surveillance across the One Health platform with our collaborators in Timor and with Menzies School of Research. So I think going forward, there's more and more opportunities to collaborate across with our partners and potentially have scholars from additional countries building on what's being done. Thanks, Emma.
Thanks, Sam. And Tambri, if you're still online, did you want to add anything about your work in PNG?
I am, sorry, I'm just juggling homeschooling as well, so I'll come in and out a bit, but yeah. So in PNG, the Hunter New England team has been supporting the Field Epi program there for the last 6 years, so I was very privileged to be able to get involved a couple of years ago. And there's a whole vision, a very exciting vision that's been developed out by the director, and we're very excited that DFAT have co-funded a position for a convener and project manager this year. So we're really fleshing out the support for the team, and it looks like now with Global Fund we're going to get extra funds to support the rollout of a frontline program, which is a short 3-month program focused on surveillance and outbreak response, but we also want to bring in a community engagement arm into that really strongly to help strengthen community-based surveillance in Papua New Guinea. So some really exciting projects, and what excites me so much is it's led by the vision of the local faculty. The community-based surveillance project was led by one of the faculty in Bougainville who's been passionate about this for a couple of years. And one of the good things about COVID, if we can celebrate them, is the money that has been invested in field epi and surveillance. So where there hasn't been funding for projects that have, our partners in country have wanted to do, now there is money available and they're able to implement some of the vision that they've wanted to do for a number of years. So there is a good side to the pandemic from the field epi perspective, in the sense that there is money being invested in this area. And I think it's building on what Sam said, it's just a great opportunity at the moment to really strengthen those collaborations between MAE program and the other programs in our region. And we already have, some strong networks with Safety Net and with partners through the ASEAN scholarships. But I really do feel that moving forward, there's going to be a lot of opportunity once borders open for some of that cross-fertilisation between faculty and fellows as well. So really looking forward to that. But yes, very exciting stuff, Emma. So it's great to see money invested in field epi. I'm very happy about that.
Thanks, Tamby. And I'd also like to acknowledge Pip Binns, who's on the line with us today, who did a tremendous amount of work in terms of setting up the ASEAN program in the early days. So thanks very much, Pip. Are there any final comments, questions? Okay, all right. So just before we break, and I acknowledge that we're running a little bit over time, but I have a very important announcement. I'd like to announce the winner of the photo competition. So congratulations to Sandra Downing for her photo titled Mudshot. Sandra, are you online? I saw you there at some point.
Yes, I'm here.
Oh, there you are. Thank you. Thanks for putting this on. Did you want to just give a 30-minute, description of what's happening in this photo?
Well, I was trying not to lose my boot in the mud, to be honest. This was in South Sudan back a few years ago in a protection of civilian camp, and my role was to set up mortality surveillance. So I was working with that other fellow there in the MSF shirt to really go out and work out how the hell we were going to do this. So yeah, it was super challenging in that environment, but an amazing experience that wouldn't have happened if I hadn't been part of the MAE program.
Thanks, Sandra, and well done. And I'd like to thank everyone who contributed photos. So we are going to go to break for 30 minutes. But during that break, we'll display all of the photos. So you'll be able to see all of the photos that were submitted for this competition. So thanks very much for everyone who contributed to the presentations for the session this morning, and for everyone who's come along to listen and ask questions. And I will see you back here in 30 minutes for some more great presentations. Ben, you've got an announcement.
Thanks, Emma. I finally realised that when you're a co-host, you can't raise your hand. Just the final session of today will be a panel discussion where we have some ex-MAEs who will be discussing how does the MAE remain relevant for the next 30 years. So if the audience want to think of any questions, happy for you to drop them in the chat over lunch break, and we can use them in the discussion. Thank you.
Sam here. Can I just say something quickly? Just want to say a big happy birthday to two of our MAE team, or ex-team, Amy Parry and Philippa Binns. So happy birthday, Pip and Amy, and what a great session and day to have for your birthday. Beats work.
Thanks, Ben and Sam, and thank you, everyone. I'll see you back here in 30 minutes.
I acknowledge and respect the Ngunnawal people, their ancestors and elders, past and present, the traditional custodians of the land on which I live and work. For those who don't know me, I'm Ben Polkinghorne. I'm currently co-convening the program with Emma, focused mainly on the domestic side. I'm not a graduate of the program, but I have been a member of the MAE community since 2014. I was a field supervisor at the Australian Government Department of Health, and I've been working on the program since 2018. The title of my presentation is From Shoe Leather to Armchair Epidemiology, the MAE 2021. Like Steph, I came up with something fairly quickly and now I'm trying to fit a talk around it. But the inaugural director of NSEF, Professor Bob Douglas, chose to copy the US Epidemic Intelligence Service logo for the MAE, which is the shoe leather picture, because he firmly believed that field epidemiology is shoe leather epidemiology. But in 2021, we've traded shoe leather for couch leather. Armchair epidemiology has inspired news stories, journal papers, podcasts, and even songs. And for me, it's been astounding to see over such a short period, epidemiology go from obscurity to fame and on through to irrelevance, because anyone with a computer now knows more than we do. But now, as the ACT has joined the Fellowship of Lockdown, it really is chair leather that I'm wearing out. I'm pleased to say that I remembered today to shave, and I even bunged on a tie, but it is lockdown, so I'm also wearing tracky dacks and slippers. I also apologise for the blurred picture and headphones. I'm not in a nice Brookfield office. I'm in our junk room, and my boys like to shout whenever I try to speak. But on to the presentation. A quick outline. I'll go through some MAE stats from our wonderful Microsoft Access database. I'll briefly mention the MAE program in 2021, recent changes and current priorities, the MAE program and COVID-19, and the challenges that we faced in 2020 and 2021. So it's been 30 years and over 30 cohorts of students. The MAE has produced 244 graduates, 70% of whom have been female and 16% of whom have been of First Nations heritage, which is an incredible achievement. From the very unscientific pie graph, you can see that the vast majority of placements have been in state or territory government health departments, reflecting our focus on acute public health, and then followed by public health research institutes and Australian government departments, which have predominantly been health, but have also included defence and Prime Minister and Cabinet. It wouldn't be an MAE presentation without an epicurve. This is graduates plotted by cohort year and field placement geographic location. You can see that since the change to the MPhil in 2012, there's been an increasing proportion of the placements in the ACT, predominantly in the Commonwealth Health Department, and also in New South Wales. And we've seen a regrettable decrease in the smaller states and territories. Looking back, it really surprised me that the size of the 1994 cohort, it was one of the largest ever, with 18 starters, including 10 of whom were enrolled in the general practice evaluation stream of the MAE, where general practitioners were placed in health departments and divisions of general practice around the country to provide an evaluation workforce. We didn't see cohorts of that size again until we had 17 in 2017 and then 19 in 2019 and 2021. We haven't conducted an alumni survey over the last few years, so the last information we have is from 2018. where 30% of alumni who responded to the survey said their first job after graduation was as an EPI in local, state, territory or federal government departments, followed by 26% who moved to research or academia, and another 15% immediately went overseas. So it'll be really interesting to run this survey again soon and see how the pandemic has changed the workforce. So the MAE as it stands in 2021, as has been alluded to earlier in the day, the field placement funds the placement. ANU pays scholar in the form of a scholarship, and it's a 22-month program starting in February and ending in December of the second year. Scholars are enrolled in a Master of Philosophy, Applied Epidemiology. There's 5 compulsory subjects: public health surveillance, outbreak investigation, analysis of public health data, issues in applied epidemiology. And these are provided normally through 3 course blocks, 3 weeks in February, March of the first year, 2 weeks in August, September of the first year, and 2 weeks in March of the second year. MAEs still are required to complete 4 major competencies: investigation of acute public health problem or threat. Doesn't specifically state outbreak because in the past we have had trouble finding every MAE a specific infectious disease outbreak. Not so much a problem anymore. Analysis of a public health data set. Establish or evaluate a surveillance system or other health information system, and design and conduct an epidemiological study. And there's also minor competencies of literature review, summarising a project for a lay audience, a presentation at a national or international conference, and an advanced draft of a peer-reviewed publication. And I forgot to include teaching of epidemiology to peers. And all of the projects in the MAE lead towards a Master of Philosophy thesis of up to 65,000 words. So, recent changes and current priorities for the MAE. In December 2018, the MAE program achieved accreditation with TEFINET, the international peak body for FETPs. And accreditation demonstrates that the MAE is producing graduates with a globally accepted standard of skills. And we found since accreditation, we've greatly increased the interest from international students in the MAE. We've been teaching in the statistical package R. While Starter is still the mainstay of our teaching, much of the innovation in applied epidemiology is working with the R statistical package. Tambry and Nidhi Menon converted many of our case studies to R, and we've also utilised the skills of our RSPH colleagues, including Erin Walsh, to provide an introduction to R for our scholars. Then in 2021, we launched a supervisors community of practice to strengthen field supervision, leadership and mentoring capacity. So far, we've had 4 workshops with academic and field supervisors to update the supervisors on the changes to the program, to welcome new supervisors. And it's a place where supervisors can learn more about the program and also learn from each other. The MAE team is now also undertaking a project on mapping the curriculum of the MAE program. We've always had an approved curriculum, but it's never been fully mapped down through to individual lesson learning objectives. This project aims to provide a better flow from each competency through the learning outcomes of the courses, the topics, the assessments and the learning objectives for each course, and to improve the accessibility of our resources for courses and topics. And we also want to make the best use of new technologies. So on to the MAE program and COVID-19. The aim of the MAE program has always been to build a highly skilled epidemiology workforce and strengthen capacity to prepare, protect and respond to health threats in Australia and our region. And MAE scholars are on the front line of the current COVID pandemic response. Many of our MAEs have deployed from their research institute placements into COVID-19 units across, and also we've had MAEs deploy across state and territory boundaries. And in the very early days of the pandemic, we did have a few international placements, international deployments. MAEs have investigated community clusters, institutional clusters and cruise ship related clusters. They've conducted analysis of pre-existing comorbidities and vulnerable groups, and they've designed and evaluated COVID-19 surveillance systems, including establishing the national first few hundred FFX study and the national COVID net surveillance network. And they've also performed routine applied epi such as case management and contact tracing. The MAE team have also contributed. Several have deployed into state and territory or national responses. In early 2020, we trained over 100 ANU and University of Canberra medical, nursing and public health students to become contact tracers. And then we worked with a Canadian FETP to design and implement online contact tracing training modules. Sorry. And these have been translated into multiple languages and hosted on the GoOn platform. And the challenges of 2020 and 2021, despite the COVID-19 pandemic being exactly the sort of public health threat the MAE exists for, it has proven to be a great challenge for the program. Firstly, as I said, MAE staff have deployed to state, territory and Australian government health departments to assist in the COVID response, and this has really stretched our team resources. And secondly, related to that, we farewelled our director, Professor Ross Andrews, Associate Professor Stephen Lambert, Dr. Tambry Housen, Dr. Pip Binns, but they all retain strong ties, including academic supervision, and we also farewelled our administrator, Beck Kelly. Thirdly, the MAE program has always been built around face-to-face teaching in Canberra at course blocks, and this has not been able to occur since March of 2020. So we've had to pivot to delivery online. It's very difficult to teach case studies, etc., via Zoom. It's much harder for scholars to separate work and study if they are trying to do course block from their home or from their workplace. And there's been that loss of the absolutely integral that everyone so far today has mentioned, the cohort networking and socialising, which is really really difficult to replace. And of course, the extended nature of the outbreak has made it difficult for MAE scholars to progress their projects. The supervisors, both academic and field, are incredibly busy and their workplaces are all stretched. Access to data sets has been reduced. It's really difficult to get data out of an organisation, even if you're internally enrolled there. The lockdowns have added more pressure to students to complete, and it's greatly reduced their ability to travel to do complete field work. So the MAE team have responded to these challenges. We've recruited great new talent to the team, Dr. Dawood Pulmazi, Dr. Rezinul Rahman in the domestic team, Dr. Sam Cahoon and Dr. Florian Voigt into the ASEAN team. We've also dragged in alumni Charlie Law and Amy Parry. and we've had the great pleasure of bringing in a new administrator, Ms. Laura Vittler, where we rapidly revised our face-to-face materials to be delivered online and as pre-recorded sessions. This has been a great trial and error. None of us had much experience in online delivery prior to the pandemic, so we've been playing catch up the whole way through. But we have pursued some upskilling in online presenting and getting assistance from the Centre for Learning and Teaching at ANU to improve the accessibility of our teaching materials. We're also ensuring a flexible approach to course blocks. We've tried postponing, but COVID keeps going. We've tried contracting, we've tried stretching them. We think we now have hit a happy medium by delivering what we would normally deliver in a 3-week period over a 4-week period, and mixing live Zoom sessions with self-directed sessions with recording. But we also have a lot of MAEs currently who are working on the ACT response at the moment, so are missing course block currently, and they'll have to try and catch up later through the recorded sessions. But we are trying to organise a time where all of the people who've missed course block can work on course block at the same time and have some MAE input to get some of that live contact. Of course, all of this has only been possible with great support we've received from our colleagues in RSPH, and particularly Professor Robin Lucas, without whom I would have been lost all through 2020, and Professor Emily Banks and Associate Professor Katie Glass, who've been absolutely critical in the last year. And on that note, Tony Stewart mentioned earlier today that a field epidemiologist needs to be able to pivot. And I can say with great admiration and respect that the MAE scholars have done just that. They've shown themselves to be flexible, resilient, and extremely hardworking. The 2019 cohort had to dump half their projects in early 2020 to pivot to COVID-19. The 2020 cohort at least had an inkling from the start that their candidacy might be unusual. But really, our classroom pep talks on what we did in SARS and what we did in swine flu really couldn't prepare anyone for the relentless nature of COVID-19. Finally, the 2021 cohort could be said to have arrived with their eyes fully open, but Delta has surprised all of us yet again. So my hat goes off to all of you. And I thought I'd finish just with a series of pictures which sort of cap it for me. This is how 2020 started at our course block in February 2020. The pandemic was just arriving, and knowing what might occur, Tambry managed to organise a PPE session at Canberra Hospital. So here they are, fresh-faced and but preparing for action. And this is what 2021 looks like. Zoom, and more Zoom. And this is what 2021 feels like. Thank you.
All right, thanks, Ben, for that presentation. I'm just mindful of time, so we could have a quick question now, or you may want to save up your questions for the the panel discussion later around how the MAE stays relevant. So I'll just see if there's one quick question before moving on. And Hayley, did you want to get your presentation? Okay, great. Thanks, Ben. And we'll move on to the first of our student presentations. So I'll hand over to Hayley Doak from the 2021 cohort. Thank you, Hayley.
Thanks so much. Hopefully that's up in a reasonable kind of way. You can hear me all right?
Yep, all good, Hayley.
Perfect. So I'm Hayley Dyke. I'm working also as a public health medicine fellowship trainee in Hobart in Tasmania. And I'll be talking today about establishing a passive adverse event surveillance system in Tasmania in the beginning of the year. So I'd first also like to acknowledge the traditional owners of the lands that we're all meeting on. Today I'm dialing in from Lutruwita, and that's the lands of the Palawa people. I'd also like to pay my respects to elders past, present and emerging, and of course to any First Nations people online today. So the scope of today's talk from me is mostly to describe the Tasmanian context and the reasons why we wanted to establish a novel passive APHI surveillance system, and some of the activities that it took us to get there, and some of the challenges and early learnings we've had from the system so far. So I'll be saying APHI a lot because adverse event following immunisation is a bit of a mouthful to say over and over. And an APHI is any untoward medical occurrence that follows immunisation. So that definition is quite broad, and that's intentional to try and catch as many events as we can. So prior to 2021, all APHI in Tasmania were reported directly to the Therapeutic Goods Administration. So any vaccine consumer or provider or healthcare provider jumped online and popped into the TGA portal their report, or could do it via email or the phone. And then once a month, the TGA would send this aggregated report back to us in public health, to our immunisation team, who'd pop it on a shared drive. And basically we didn't really look at it again because it took on average about 18.4 days for that report to get to the TGA, then back to us. So it wasn't particularly granular or useful data for us to work with. I wanted to note in the beginning that AusVac Safety, which is run by the National Centre for Immunisation Research and Surveillance, has had Sentinel sites in Tasmania for some time, and they're still running throughout the COVID-19 mass vax rollout, but active surveillance is just outside of the scope of today's talk. I wanted to bring this talk, and I'm really excited to talk about it today, because it's a beautiful example, I feel, of how having MAE candidates and graduates in your workplace continuously provides these amazing sort of workflow situations, because Dr. Gabriella Willis, who used to sit where I sit, is now a graduate, and in 2019 she published her thesis with a chapter on our Tasmanian APHI surveillance system that she evaluated in 2018. And so when it came around this year to deciding how we were going to set up this surveillance system, we had this beautiful evaluation just sitting there ready for us to look at, with all the pros and the cons set out ready to go, and we used it often as a reference document when we were setting up this system. So this is a little graphic I made just of the key events in setting up our surveillance system throughout time. So I'll be using it to keep myself on track. We'll start at the start. So on the 13th of November in 2020, National Cabinet endorsed the Australian COVID-19 vaccination policy, and in that same month there were multiple announcements that Australia had secured various deals for more doses of Pfizer or Novavax, so that didn't work out, and AstraZeneca vaccines, and indicated that they'd probably be available in March in 2021. And so we had a lot of local mass vaccination meetings ongoing from October, discussing how that would even look, rolling that out in Tasmania. And part of that discussion was about adverse events. So we knew at the time that we had a brand new vaccine for a brand new emerging disease in a scale that Australia had not attempted before, and that the public and media scrutiny on it was going to be quite enormous. And that part of propelling that, propelling the mass vaccination program forward would be maintaining public trust and needing information to be passing along at the time. So it became obvious, as I said, from Dr. Willis's evaluation that there was a gap in surveillance that was needing to be filled, and this was maybe the time to do it. So we drafted up terms of reference for an APHI working group, and that membership originally consisted of the public health physician Shannon and myself, our immunisation clinical nurse consultants. We had GPs from Primary Health Tasmania, specialist immunologists, vaccine content experts, any stakeholder we could get to the table, we got them there to talk about adverse events, and had our first meeting on the 11th of December in 2020. So then we had Christmas, we had a little break, though not everyone had a break. And on the 7th, Greg Hunt announced that the national COVID-19 vaccination program would start in mid to late February. And we had a small moment of panic when we realised that was only 5 to 6 weeks away from where we were. So the Tasmanian Vaccination Emergency Operations Centre was stood up on January 11th, which kind of signalled that this was coming, this was real, it kind of kicked us into gear. And so we drafted up a number of options for surveillance of how we could potentially look at adverse events, and they were these. So we could leave the AP surveillance as it was, going straight to the TGA. It was simple. It was not resource intensive. It was reliable. Everyone kind of knew how it worked and had been using it for forever. We could beef up the AusVac safety, so enhance our active surveillance and leave passive alone. Or we could make a whole new passive surveillance system, which was the most resource intensive option we had, but it would provide better ascertainment, it would give us better data quality, and ultimately it would be timely and useful for us. And so that's what we ended up deciding to pitch and run with. So I set about building this thing. So case definitions, surveillance objectives, case reporting forms, standard operating procedures, making clinical pathways all drafted up, and creating some communications plans of how we were going to tell everyone what we'd done. And we went from a conceptual draft to a working draft in a bit under 2 weeks. It was just a rapidly accelerated process. And we were working originally within the understanding that the Tasmanian vaccine data solution that we were building for vaccine administration had this APHI function that we could just turn on and plug the information in, and it would theoretically be quite good. And then we sort of hit February, as you can see on the map, quite a few things went on. And so in the very dying days of January, we realised that, in fact, that data solution APHI function wasn't going to be turned on for a minimum 6 to 8 weeks into the rollout, and that it would only be for COVID vaccines. And it was quite a disappointing moment for us, because we'd seen this policy window to establish a surveillance system that years ago a brilliant MAE grad told us there was this big surveillance gap in Tasmania, and this was the chance to fix it. So we were looking at, legacy beyond the COVID-19 mass vaccination rollout and setting up this thing for Tasmania. So this wasn't a great revelation for us. We were a bit upset about it. So we worked out that we could build a REDCap database in the interim. And in a few working days, we'd worked this idea out. And we are still using that same database now, which is just as well we had a thought all the way back then. So our amazing epidemiology team set up this REDCap database in a matter of days. So by the 13th, we had a testing environment ready. We set March 1 as our live date. We thought that was a reasonable target. So we executed our communications plan. By mid-February, told everyone internally, externally, in all of Tasmania that we'd changed the system. We gave our first vaccines on the 22nd, and by the 27th, our first handful of APHI reports came through, and we got to pop them into REDCap ahead of schedule, which was a really exciting moment for the whole team. So the things that went well, we got to our live date on the 1st of March. That was a big win. And 6 months down the track now, we're about to tick over 2,300 reports in that same database. And just to put it in context, in 2019, for the whole of Australia for the entire year, there were 3,700 APHI reports recorded. So we are well sort of on our way to getting right up there with that number, which is just unbelievable for our little system. And our APHI rate per vaccinated population for the rollout has been consistently the highest of the jurisdictions. So that means that a lot of local information has been available for the public and for our vaccine providers, and we've been able to engage with people directly and keep a bit of that trust and momentum in the rollout. And having that control over the database locally by being REDCap gave us a lot of flexibility for all the twists and turns that have happened, as we're all aware, in the vaccination rollout so far, so that we can make same-day changes and be right on top of it. The biggest thing, I think, if we could go back in time and fix, we would make sure our clinical pathways were solidified and well sorted out, given how many serious AFI and contraindications and second dose arguments have been had for all the various vaccines, that it's only just now that we've sort of got a formal clinical pathway really sorted out. So 6 months is a long time to be trying to support that in not quite the right environment. We did a really good job of reaching the GPs in advance. We did a less good job of thinking about other players like private hospitals, who obviously had a big part to play in having serious adverse events turning up to their EDs, and then those reports not coming to us in a timely way. Our AFI team's very small. We've got 2 nurses at any time and sort of 2 medical support officers competing with other duties at the same time. So it's been an enormous workload for a teeny tiny team. So probably would like to put more people on it. And moving forward, the next things that happen now. So it's 6 months down the track. I'll be doing a formal evaluation as part of my chapter, and part of that might be some recommendations like making AFI notifiable under legislation, or looking at other ways that we can improve the system as it is. But I'll leave these names up for a second, all the people that have been involved, and that's it for me. And then I'll be right for some questions. But I might stop sharing so I can see people's faces.
Thanks, Hayley. Great presentation. I think we've got time for 2 questions. I see Gabby has a hand up.
Gabby!
Hi, Hayley. Thank you. So more of a comment than a question. So I'm Gabby Willis, and thank you for the lovely acknowledgement of my work, Hayley. I guess I just wanted to comment that, yeah, from my perspective, when I did this MAE, when I did this MAE project, I think I naively thought that all my recommendations would be nicely put into place quickly, and I did find it quite frustrating that then it seemed to just sit on a shelf. And I think that it was a really good lesson in policy windows for me. And I can't tell you how thrilled I was when Shannon told me that it was being used and was being useful in this context. So yeah, thank you to Hayley and all the team in the Tasmanian Department of Health who've used this work and taken it forward. And I suppose just bringing around the full circle of MAE, I just wanted to acknowledge that Dr. Mark Veach, who is also an MAE was the person who pushed me into doing this project as my evaluation project, and was the one who initially acknowledged it as such an important issue. So yeah, thank you.
Noni, did I see your hand up?
Yeah, thanks, Hayley. Really interesting presentation. Looks like an interesting project with a lot of hard work. Just wondering how the system links up with the TGA and kind of what integration there is with the systems.
So the TGA, just for COVID-19, created basically like this little portal that you just upload CSV files. So you just extract the CSV out of anything and chuck it into their portal. So it was quite easy to do no matter what database or platform we decided to use on this end, as long as it could generate a file that looked like that.
Thanks.
Thanks so much, Hayley. Well done.
Thank you.
I'd now like to introduce Fran Sheehan from MAE 2020, an experienced communicable diseases nurse and public health officer from Queensland. And Fran chose to go back to her clinical roots for her placement and joined the Canberra Hospital Infectious Diseases Unit, leading to this project on AMR.
Thanks, Ben. That was a really generous introduction. Makes me sound fancier than I am, I think. So Yulma, everyone, good afternoon from Ngunnawal country, the country here where the sovereignty was never ceded on the land. And we need meaningful reconciliation to improve the health outcomes of our First Nations people. And so I support a treaty reparation and self-determination for our First Nations people. I'd like to thank the Ngunnawal and the Ngambri people for their ongoing custodianship of this land and for allowing me to walk on their land. And also a special shout out to any Aboriginal and Torres Strait Islander people who are attending the event today. And to everybody else who stayed on the line, I didn't think so many people would stay on after lunchtime. So it's lovely to see the numbers still quite large. So I will share my screen now with everybody. As Ben said, I'm going to talk to you today about a slightly clinical topic, but I think hopefully by the end of it, you will realise it's really a public health topic. So my placement is at the Department of Infectious Diseases at the Canberra Hospital, and I'm going to be talking to you about why we aren't making progress on antimicrobial resistance in Australia, and if it's our lack of accurate epidemiology. So just briefly as an overview, antimicrobial resistance, or AMR, is when an antimicrobial, so that's an antibiotic, antifungal, antiparasitic or antiviral, becomes resistant to its corresponding organism. It's a global health threat, whether you live in a high, middle or low income country. And in 2009, it was listed as, 2019, it was listed as one of the top 10 global threats to health. And for those of us who've been working in public health, I'm not sure we can remember what actually happened in 2019 anymore. Here in Australia, from a human health perspective, they estimate there's only about 290 deaths annually, but that's an underestimation considering that the results of AMR can be hidden under other conditions. Australia has the highest use of antimicrobials in a hospital setting when you compare us to Europe and Canada, and we're 7th highest when you antimicrobial use in community compared to that same reference group. And as you can see from the slides there, that national resistance rates for priority organisms have not changed substantially from 2017. So why aren't we making progress on AMR in Australia? Part of it could be the complexity of the settings and the responsibilities of AMR. In terms of settings, it's across all health settings, whether it's the community, acute hospital setting or residential and aged care. I've just listed some of the organisms that we have come to associate with those settings. But then below that, you can see that the responsibilities are multi-sectorial across the human health sector, but also in animal health, in food production. And then all of those multi-sectorial agencies then makes it difficult to know who's responsible and who's in charge. So from a surveillance and reporting perspective, in Australia we have the Antimicrobial Use and Resistance in Australia Surveillance System, or the AURA system, and they've just released their 2021 report. And this is a nationally coordinated system, but it's not a national representative system in terms of we're not receiving consistent data from all the health services across all the jurisdictions in Australia. We also have a lack of consistency in laboratory definitions and surveillance definitions because there's no overarching bodies like PHLN or an NNDSS that are providing us with those standardised definitions. So with all of that background, I'm going to talk to you a little bit about what I've been doing at the Canberra Hospital. One of my studies is into the epidemiology of extended spectrum beta-lactamase Escherichia coli isolates in the Canberra Health Services referral network for a 5-year period, 2016 to 2020. That's a bit of a mouthful, so we just call them ESBL, E. coli, and ESBL is a type, very simply, a type of antibiotic resistance to 3rd generation cephalosporins. So the aim of the study was to determine whether there was an increase in the episodes of ESBL, E. coli, but also to describe the antibiotic sensitivity patterns, looking at pre-existing medical conditions of the patients, their healthcare utilisation, and also classify the onset of the isolates. So you can see from that flow chart there, it's just, there's quite a number of databases that are needed to be interrogated to then get the data that's needed. But the wonderful thing about research here in the ACT is that the Canberra Hospital is the only tertiary referral hospital for ACT and the Southern New South Wales region. And ACT Pathology is a large service provider in the region. So particularly when we're looking at blood isolates, we have an almost complete picture of the region. So I'm going to focus specifically on onset classifications, because this is one that's used widely by AURA and this AGAR, which is the Australian Group on Antibiotic Resistance. And it's a dichotomous variable of hospital or community onset based on the time classification of when the blood sample was taken. So for a hospital onset, it needs to be taken greater than 48 hours after hospital admission, and everything else is classed as community onset, including if they're taking in an outpatient setting. So you can see on the left-hand side of this table, if we apply that surveillance definition, just using those two variables, we get the picture that 72% or 80 of the 111 isolates are classed as community onset. And I will point out this is only for a 4-year period because we are waiting for the 2020 AGAR data to come. So the overall study will be 5 years, but what I'm presenting here is just 4 at the moment and will be updated. But then what we did is we applied an enhanced surveillance framework using those different data sets that I identified in the previous slide. And we've got much more sensitive information. And you can see there's interactions with acute health care over certain time periods, aged care associated, and previous infections and travel. And when you apply this enhanced surveillance framework, you can see that it's only 13 of those isolates, or 12%, that we've then defined as being community acquired, or onset and acquired, but we won't go into that. So what does this mean and why does it matter? The current definitions, they're simply defined, they're easy to collect, they're based on the time that the sample was taken. But are these definitions harmful or helpful? And we go back to that data from my study, which paints a very different picture. And this matters in terms of the assumptions that we might make from the data. So from the 2019 AGAR sepsis outcome report, they've then made the assumption based on these surveillance definitions that ESBLs are no longer primarily a hospital problem and that the resistance occurs in the community. And if we're mislabeling the epi, then we're going to have these misleading assumptions. And that has knock-on effects for how we strategically plan for our priorities in healthcare and how we allocate resources. So what can we do to improve AMR epidemiology in Australia? The first point I'd like to make is that AMR is a public health problem. And there might be a few of you on the line going, oh, is it? It's probably really a clinical problem. Is it really a public health problem? But changing the perception is that first step. AMR straddles infectious diseases and chronic diseases because it can become a chronic disease for people. And also Professor Anne Duggan, who is the lead of the AURA group, when they released a report just a couple of weeks ago, she challenged us to take a step back and look at the mitigation of AMR through the lens of chronic diseases such as COPD, type 2 diabetes and otitis media. So nationally, we have a recently released antimicrobial resistance strategy for 2020 and beyond. And in that, the federal government has committed to establishing a One Health surveillance system. So that'll include animal and human health, and public health is best placed to lead the establishment of this surveillance system, and we need to be in this space. Locally, there is a large value in embedding epidemiology in these clinical settings and bridging that divide between public and clinical health. So what's the role of the MAE and field epidemiology in general in a hospital setting? I asked the MAE team to look back through previous placements to see others apart from myself who'd done a purely clinical field placement, and the only one that we were able to locate was way back in 1994 and 95. So at the moment, the MAE and field epidemiology in general isn't contributing to this section of the workforce. Recent scholars have been seconded to hospitals for a single project, which has usually been in the outbreak setting of a multi-resistant organism, which again perpetuates those thoughts about that it's an acute problem in a hospital rather than a population-based issue. And I think generally COVID-19 has highlighted the lack of good hospital-based epidemiology in general. And I think that it's also shown us that the apocalyptic post-antibiotic world that people are talking about and not being able to treat serious diseases is not as far off as we thought it might have been when we were talking about this a couple of years ago. So in the same way, Linda earlier challenged us to try to incorporate climate change and more environmental health in the MAE. My challenge for the panel discussion would be how can we bridge this clinical and public health divide and make real inroads into the epidemiology of AMR in Australia. I'd just like to acknowledge my field supervisors, Nick and Catherine, and my academic supervisor, Meru. And then the other member of this study team is Karina Kennedy, who's the head of clinical micro at the hospital. I'd like to thank ACT Pathology and the Infection Prevention Control Unit at the hospital, and also AGAR for their data in helping me complete this study. And I'm happy to take any questions or challenges on the thoughts of AMR as a public health issue. Thank you.
Thanks, Fran. I really like the way you've posed that question. And certainly, given it was me that ran over time, I'm not going to stop you from having some questions. So please, we'll take 2 questions.
I'm going to take silence as that everybody agrees with me.
Absolutely. My question for you, Fran, would be, given your thoughts, something that I've been with the MAE team have been throwing around in recent months is the idea of maybe going back towards streaming of the MAE, looking at perhaps chronic diseases, perhaps clinical epidemiology. Is that something that you think might be a way to tackle this problem?
Yeah, I don't think it's a bad idea, Ben. I think I suppose the risk with that might be that people might feel siloed or not have a breadth of experience. But I suppose generally at the moment, most of the settings are in sort of the communicable disease sections or similar of jurisdictional health departments. So people might not be getting that cross-section of chronic disease or environmental health. So I think that's a valid way of doing things. But again, it's, I suppose, how we define field epidemiology in settings that might be seen to be a bit more research-based.
Yeah, great point. And we've heard the same the same concerns about the silos. So yeah, it's definitely an idea that needs a lot of working up. We also, Professor Gruen.
My question is very similar, Fran. I'm curious about your experience working in an acute hospital ID department as your placement, and how does that? What have you taken out of that for the MAE program, and what can we learn for the program?
Thanks, Professor Gruen. I think generally it's, and I have given this feedback to the program. I think they're sick of my feedback. Is around the scaffolding to support settings that haven't traditionally been MAE field placements. And I think my supervisor, Meru, is online, and she has had to, I suppose, maybe have a more active part in some of the things around the administrative side and providing epidemiological support, because that hasn't been able to be provided in my workplace. So I think that's a consideration for the program in terms of how you support these placements that aren't as traditional. I didn't really think I would find AMR so interesting. I'm going to be honest. I started my career in true public health and then went to clinical and have come back. And I took this placement for a variety of reasons, but I've actually enjoyed it far more than I thought. So, sometimes we can surprise ourselves as well. And I think I've been well supported, even though my supervisors can't give me the technical support. They certainly have the drive and the charisma to get things done. One of my supervisors spends a lot of time on the television. So he has a way of bringing people along with his vision a lot of times. So they're skills in itself in terms of getting stuff done. But yeah, I think I'm quite a advocate for these non-traditional settings to advance the field and advance, I suppose, health outcomes generally.
Thank you. That's none of that surprises me. And it's good to hear that you're getting these what are going to be valuable skills for you, especially in your future career. Yeah.
All right. Thanks so much, Fran. We had better move on. Our final speaker is Dr. Mario Vitorino from MAE 2018. He is an ophthalmologist by training and is pursuing the MAE within his workplace at the Therapeutic Goods Administration. And his talk looks at a problem of ophthalmology through a public health lens.
Thank you, Ben. Can you hear me?
Yes, indeed.
Oh, well, fantastic. Well, thank you for inviting me. First of all, I really appreciate this, and all the speakers have been really great, and I have learned quite a lot, so that's good after these few months of COVID and lockdowns and things. So it has been very good to be back with some of the people from the MAE cohort. So I'm gonna try to be and try to go quickly through my slides, but I want to give you a certain message through the presentation, and hopefully I can convey that during it, is how we can combine things from a different placement or a different environment with the things that we learn in the MAE, and that's why what the title of the presentation was. It's in an unusual placement anyway, TGA. So I work for the Department of Health basically, and during this presentation I want to just give a little bit of introduction to where I work, then talk a little bit about why it's relevant, this project that I have been working on, a background of the disease or adverse event that we are investigating, something about the methods, then a little bit of why this was an outbreak or considered as an outbreak, some parts of the results and analysis, and some conclusions. So, all right. So, well, just a few things about my field placement is basically the TGA. And well, people now know more about the TGA these days, but is part of the Australian government, the Department of Health, and we basically regulate many things, including medicines, vitamins, minerals, vaccines, for example, topical at this point, so sunscreens, blood products, and finally medical devices. And I want to talk about medical devices in particular, because actually I work for that section or that branch in a section called clinical section. And we give clinical advice to many sections in the devices branch. Well, the thing about regulation of medical devices is that it's usually regulated depending on the level of risk of the devices. And you can imagine if, for example, a device is an implantable device, risks are usually higher. But in the TGA, we're usually looking at things like quality, safety, and performance of the devices. And but it's the whole life cycle of the device, including, for example, which is going to be important for this presentation, for example, things like the manufacturing processes. So that's basically what we do. But even for that, when something new comes to the market, usually it's going to be included in that register that we have. It's called the ARTG, the Australian Register of Therapeutic Goods. But during that life cycle, we are monitoring each one of the steps and including adverse events. So I have here some, well, medical devices could be anything like Band-Aid or just pressure monitors, or even things that look like medicines like drops for the eyes, or auditive implants, or things that could be like pacemakers or preservatives, or even this machine that's going to be important for the presentation today, and I'll talk about it. It's a machine for doing cataract surgery. So the first thing is about the outbreak. So this project was, and we developed this acronym is about intraocular lenses opacification, IOLO. So this is a normal routine intraocular lens, but you can see all these white deposits, which are basically calcification in the surface. So if a patient has something like this, well, he won't be able to see, basically. So why is this important to the TGA anyway? So if we look at the things, and you remember maybe that ARTG that I was mentioning, so there are many things that we get adverse events reports in this column. And in the top 10 of them, for example, you can see that this number here of the ARTG is actually an intraocular lens. It's not the same one that we are looking in the, but it's something that is quite used in clinical practice, so it's very relevant in that sense. And if we look at, for example, this is like GMDN codes, it's like the family of products. Even the top of them, also in number 4 is also intraocular lenses. So intraocular lenses is a device that is widely used, and actually we can see many adverse event reports. And I just put in this video, so it's just a little bit of background of what we do usually when we are doing a cataract surgery. So we are taking out, which is this one is just getting a chopper, is another medical device, to get and crack the cataract into pieces. And then after that, you're gonna put, because the cataract was obstructing the vision, you take all of that out of the eye, and then with another device that we're gonna put in a moment, this is the tip of the device I showed you before, of the phaco emulsificator. It's just with ultrasound, tearing the cataract apart, emulsifying it, and then aspirating it. After you get all of this done, and this is real time actually, the surgeon is doing that in real time, it could be really quick. You get the whole thing clean, and then you put, after that, a lens inside. I just stopped this one for a sec. But and I just show you a little bit about the lenses here. So in this case, for example, you can see that here we're putting, after cleaning, put some viscoelastic, like it's a gel, putting the incision a little bit bigger, and then with the injector, this is the cartridge, we are putting the lens in. And the lens look like similar to the other one. This is something that should be transparent. Just the lens is putting in there, and then after that it expands, and that's it, cataract is done. I just stop this one and go for the next one. All right, so the first question that we have is, was this an outbreak? And actually we have some, we were contacted by the post-market team getting the adverse events reports, and some clinical advice was required, and that's where I started looking at these cases. And these cases of opacification of IOLO are really rare. When we look at the literature, it wasn't that many that were reported, and usually they occur in the late post-operative period. The causes are unknown, but they are related to some things. Apparently, there's something related to ocular inflammation. For example, if you have a trauma, or for example, a complicated cataract surgery, for example, retinal surgery, or for example, diabetes as a systemic comorbidity, it may contribute to the processes. So that's also important to note. The other thing also for this case, the cases investigation, was that also other things, like for example, manufacturing processes, for example, something in the packages, some impurities or something could cause that, and it has been related to high incidences of this IOLO. So this was definitely an acute health problem. So if you have a patient like this, that should be clear, and then you see here in the right that the lens is cloudy, then well, the patient's not going to be happy, and they cannot see the lens has to be expanded, and then you have to put another one, increasing the risk for that patient. We have some issues anyway with the way that things are reported to us. So for example, we have to take into consideration duplicates that were in our system when we got the reports. The system, which is called here Infolida, is sometimes not that user-friendly, I would say. So it's sometimes difficult to search. And it takes some time. That's another thing that we find it challenging, is that sometimes it takes some time to have that final report. So the adverse events reported at the beginning, and then we got this, after a few months even, the final report with final findings. So that's something to consider as well. What were the methods that we used? Well, actually, we basically did a descriptive case series. And what we try to do is to put all those that you probably really well know, the 10 steps of the disease outbreak investigation, into this new environment, which is regulation, basically. and applied to medical devices in this case because it was in an intraocular lens. Many challenges along the way, and I think that's one of the good things that I learned about all the experiences. Well, for example, my cases, sometimes it was complicated to determine them, and that's why I put here the cases definition that we came up with. But other challenges that we found is, for example, the denominator. It wasn't easy because sometimes this, what we get is not actually the devices that has been implanted. We get basically things like devices shipped or even sales for the device. So we have to work with that as well. And the other thing was really important is compared to what. So actually, if we want to do an exhaustive investigation, we have to go for a full product review of the whole range of family of devices, which is more complicated and resource intensive. And sometimes we have that comparison is quite difficult, and we have to go, for example, with comparison with the literature, for example. The other thing about this is confidentiality issues, as you know, and we're working in a thing which has some commercial interests and things that could be challenging as well. So a few facts about what we got. So some results. We look at a certain type of lens. We call it Y, and this has been licensed for many years now, 13 years. But and it has been, there have been many reports of adverse events for this one. For example, almost 15 the last 5 years. But from the cases of Aiolo, we found that there were 13 cases during this outbreak. And I will show you some figures about that. I put there something about the age and the gender of the patients affected, but I want to maybe just quickly check about the gender. So this is the comparison between male and female. More females were reported. But the thing about that is if we look at them closely, actually not reported for those 13 cases that we had, actually is almost the half of the, so we had quite a lot of incomplete data for that type of measurement, so variable. So it's really important to know that. Another thing that I quickly want to show you is the mean delay in reporting to the TGA. So since the adverse events was detected or reported to, for example, the company, and the delay that is there to talk to the TGA, it was in average 102 days, but it could range even to 583 days until we get to know that. So there are a few things around that need to be fixed. But the other thing that's important about the results that we got is actually that we got some, it was consistent with what's reported in literature. Some relevant ophthalmic conditions, like, for example, retinal detachments that were treated or corneal grafts were seen in a high number, or things that show that the surgery was complicated when the surgeon used gas or silicone oil to repair, for example, a retinal detachment. So in that case, that's also consistent. And the last thing that I want to note about that, the things that we got is that when we look at the rate of complaints, initially, for example, the rate in Australia was higher, and that's what started the whole process of investigation. So it was actually 4 times, a little bit more than 4 times higher than was worldwide. But it's a rare adverse event. So it was 0.09, the rate of the adverse event here in Australia. So if we put it by million, well, the numbers look a little bit prettier. But in that case, even when we have the full data now from 2000, just starting from 2016 to 2020, even the rate in Australia was not even 4 times. It was almost 10 times higher. So it's really important to know that as well. So I want to show you quickly the epi curve that we have. So since you can see that there's a little bit of a baseline here at the very beginning. So no cases at all. Then we start having the cases in late 2016. And these cases went, and these were when we were engaged into the process of this. And maybe I just show you the first epi curve that we have, that when I did a presentation before, or I submitted a poster to a couple of conferences, but we have some cases, weren't that many, each quarter of the year, 1 or 2 cases. And then we got this at the beginning, it was one of the probable cases that got confirmed a bit later in the second presentation that we have. But the interesting thing is that when I looked recently at the data, we have this huge spike well, a pretty huge spike, it's only 4 cases, but it was in late 2019. If we look closer, maybe, well, is this another thing that we need to worry about? And one of the things that I commented before is that sometimes the delay in reporting is really important. If we take this spike and look at what was the real day that it came to the company, that the company name about it, then the spike just vanishes, because the spike was here, and for those 4 cases, one is actually the spike was here, and so 3 of those cases weren't actually still there. So 2 were actually in the first quarter of 2019, and the other case was actually even before. That's the 583 days that I was mentioning before. So actually the case was not reported to TGA, and when we asked for that, well, the company basically explained that they had a problem in the reporting line. So what were the plausible explanations for this type of outbreak? So one of the things that the company told us at the very beginning was that it could be a really, we are a small market. And well, in that case, just a few cases will just see that the rates are really high. But that doesn't sound really good. Well, the cases were actually or you could see there were cases in most of the states. But I think that it's more about the different regulations and rules that we have and how we report things in comparison from Australia to other places in the world. And going more with that is actually, for example, we could see that most of the reports, the source of the reports was actually the sponsor. So the company which is supplying the product is the most of the reporting that's common, I think. But one of the things that I also want to highlight is that 15% of the reports of those 13 cases actually came from the specialists. So, and usually when when the specialists were reporting, usually it tend to be when those spikes were in our database. So that's interesting. There's a little bit of what are the things that are
going to need to wrap it up, Mara.
Yep. Main things to report. And well, so we came up with 2 hypotheses. One is one surgeon was a super spreader. So maybe one surgeon was reporting more than normal, but we just took off the cases of the surgeon. And then we saw, oh, well, actually that surgeon, even the rate in Australia, the complaint rate was really high. So it doesn't matter if we took actually the surgeon out of the equation. And the other thing is very important is how the Australia compared to other countries. And in that case, for example, you can see that our complaint rate is really high. This was the initial one that we got. And even if we look at now the latest report that we have, even you can see that the rate in Australia has been very high, and it resembles a little bit the worldwide rate. So actually it was a problem there. The hypothesis too was basically that probably the manufacturer wasn't doing the right thing. But in this, basically, I am saying in this slide that basically they were searching for the things. We were able to corroborate that with the laboratory analysis that they did, and we couldn't find anything. What we achieved so far. So basically, well, I think we achieved many things, but one of the things now that we identified the problem, the company was able to implement that in the instruction for the user. So actually they have now something saying that calcification could be a problem. And they list there some of the things that we also identified and is consistent with the literature. And finally, what about the future? So conclusions from this. So the small market theory, I don't think it is really important, but there are other things like over-reporting that could be a cause, but I think that over-reporting is not the real thing. It's actually that we need to report. Actually, we need to encourage people reporting. There's also, well, some things about difficult cases. All of these were difficult cases. We couldn't find any batch that was related, that, for example, that's a cause in the literature. And there are some limitations in our approach. How can we make, for example, our data better? And that's why I mentioned also some projects that we have in the TGA, like making a unique product identifier, which is the UPI, or putting registries in place. So I think that's an opportunity for us, and learning things from a different environment, which is the field epidemiology, is a way to put things into perspective in the TGI. And we need people like this and different thinking, I think. Well, just acknowledgement for the people that have been working with me, Ben especially. Well, my boss at work, Simons, and the organization, the company said was really helpful because I have to deal with them quite a lot, the family for the patients. So if any questions, I don't know, Ben, if we have time.
Thanks, Mario. We'll take one or two questions. Okay, thanks, Mario.
No worries. Thank you. Thank you.
Thanks, everybody. Thanks for sticking with us through to the end of the day. It's been fabulous. Not what we envisaged when we first thought about this 12 months ago. We were hoping for a joyous celebration together, but it's really gone very well. Thank you all for your support. Our final session is a panel discussion looking at how the MAE can stay relevant over the next 30 years. I just want to check that our panel members have all managed to get online. Tony Stewart from MAE 1991, still there, yes. Stephen Lambert from MAE 1996 has been here, yes. Gina Saman from MAE 2003, are you there?
I'm here, Ben.
Hi, Gina. Kate Astridge from MAE 2010.
Hi, I'm here.
Hi, Kate. Natalie Strobel from MAE 2017.
Yes, I'm here.
Terrific. And Caitlin Vetty from MAE 2017.
Also here, Ben. Thanks.
And the facilitator for this session is Professor Robin Lucas.
Thanks, Ben. I have to say I'm not at all sure how you do a panel discussion on Zoom when you can only see a third of the people on your screen. But what I thought we might do is get each of our panellists to maybe speak for just 2 or 3 minutes on the question, how does the MAE stay relevant? And then we ask the audience to just chime in with some comments or some questions to our panel. So if that sounds all right to our panellists, I'll hand over to you, Tony, to get us started.
Great, thanks, Robin. Yeah, wave the flag. Time seems to tick differently when you're speaking versus when you're listening. So just let me know if we go too long. I'm talking to you at the moment from Boonwurrung country, which is in the Kulin Nation in the south of Victoria, and acknowledge the leaders, past, present and emerging. I think it's really important in saying that we also need to reflect on what that means in our day-to-day practice and what it means for the MAE. And I think Jocelyn Jones summed it up really nicely, saying that Indigenous health is a mainstream thing, and we still have a lot of work to do in that regard. And I think that's one of the things that we can build upon, knowing that we already have an Indigenous stream, but it's not a separate stream. It needs to become mainstream. We heard several journeys from people in their public health careers, and we all have one that's unique. They're all very different. I mean, very quickly, I started a clinical work. I did some clinical jobs in Australia and the UK. Somehow found myself in Vanuatu, and somehow out of a clinical job got involved with doing a sero survey on hepatitis B and realised there was this whole world of health outside of a hospital. First job I'd had where I was doing something outside of a hospital. And at that time, one of the people I was working with said, "Oh, have you heard of this new program at ANU?" And I hadn't. I didn't really even know what epidemiology was at that point. So that's really how my career started. I was looking, in hospitals at things like, kids coming in with malnutrition, vaccine preventable diseases, people with hepatocellular carcinoma, and nothing that we could do in a hospital would really change that much at all. And so it really was, the turning point in my career. When I came and met Bob Douglas, it was like I found my home. I found the thing that I was looking for. So that was really sort of my story in brief. I think the important things are now more than ever, the pandemic has shown us that the original premise for the MAE is as relevant now as it ever was. It's about preparing people, having those people knowing what to do, and really, coming back to those roots is really important. And Ross summed it up nicely about, being able to prepare, protect, and respond to health threats is really important. Pardon me. The original concept was this three-way relationship between the student, the university, and the field placement with the Commonwealth in there. And I think that really is something that we need to strengthen and expand upon. We started very much as a national program, but it's grown over time to be regional and international. And I think there's a lot of exciting things to do there to keep the program relevant. Linda talked about the climate crisis. And I mean, First Nation people have always known that there's this connection between the environment, between health. They're interconnected. We can't separate them, but it's not the way I was taught. And I think it's really important now that we refocus on that sort of one health approach where everything, the environment, the human health, animal health, are all interconnected, and that we need to sort of bring that into focus as well. We heard about the need for equity, both globally and within Australia, and I think as public health practitioners, that's something that we should strive for. And whenever we see inequities, that there's work to be done there, and that can be something that drives the direction of the program going forward. I really see the program being something like a tool where we can have people who have the time to be mentored and to be able to gather evidence on things which are going to make a difference, things that are going to influence policy. We need the priorities set by the jurisdictions, by national bodies like CDNA and so on. But then to be able to use the program to gather that evidence that will have information. One of the things I'm particularly keen on is making sure that we have the right tools as well. And I think we learn statistical tools and things like that, but we saw in the pandemic, we saw in West Africa, see in just about every major event, sudden plethora of people who can build something. I've got an app that'll do that. It's almost impossible to roll those out in real time in the heat of an outbreak. And these are things that we could support the development of, the testing of, the validation of ahead of time, and things which will can be rolled out in an organised way when there is a need for them. So I think pushing for those sorts of things as well, tools that would help with digital tracing, visualising chains of transmission, the sorts of things that we have now but really needed to have 18 months ago for the pandemic, are just as relevant to other sorts of outbreaks as well. We mentioned...
Tony, I'm going to stop you there because you've had your 5 minutes. But stay on the line, because I think just for me that's raised a whole lot of questions, but I'm going to let the other panellists have a bit of a go first. So on to you, Stephen.
Thanks, Robin. I've just a few things to add to Tony's suggestions, and certainly agree that environmental, animal health and the intersections with human health are really important parts of what we should think about the MAEs providing. I guess to take a more procedural look at things, how to keep the MAE relevant. So I guess over time, one of the things I've always advocated for in the program is to make sure that we keep alive admitting a range of students from a range of backgrounds, being very important to take people with different life experiences and different stages in their career. So whilst it's always good to have, a highly functioning 40-year-old who can operate autonomously and require very little supervision in the workplace, I think equally as exciting is the 25-year-old who is really enthusiastic and driven about learning more about public health. And I think making sure that we have a mix across experiences and skills in the program is important to keep it relevant. Just harking back to one of the comments I made this morning after Raina's talk, that I think it would be good to do a review or a Royal Commission or something into our response to the pandemic, and thinking about what gaps applied epidemiology had in terms of responding. Working in Queensland Health during the outbreak, I think one of the things that we haven't prepared for as well as we could have is this idea around digital processes to streamline activity, that we've had to spend an enormous amount of human time, human resources, doing very mundane activities that were essential for responding to the outbreak but that perhaps no one outside of communicable diseases had any visibility that we couldn't do these things in an automated way, because we all use cell phones, we can all check our internet banking. What do you mean we can't have sophisticated notification systems that allow us to manipulate data quickly and be certain of the outcomes? So I think making sure that we find gaps in the way we apply our epidemiology in pandemic response, but in health departments generally, will be important. And I guess the last thing is to consider how the program might interact with and support workplaces in a more fulsome way. I know there's been work done on this, but I think in the next 5 years, thinking about what health departments in particular are going to look like, all I can see is capacity constraints, and that already stretched supervisors are going to be even more stretched in the future. So thinking about how we can make their role as supervisors be more efficient and more effective with support from the program, which probably means changes in the way the program interacts with supervisors, but is perhaps also resourced specifically for workplace supervisor support. Those were the things I've jotted down during the day. Thanks, Robin.
Thanks, Stephen. Again, some really interesting points from a slightly different viewpoint, some of the really sort of practical things to think about going forward. But I'll save comments and questions and ask Gina to give us her thoughts.
Good morning, everyone. Greetings from Geneva, Switzerland. So happy birthday, first of all, to all of us. Proud MAE students sitting here with you today, and apologies I couldn't join from the beginning, but glad to hear the work that's going on, and also the comments from Tony and Stephen. In my mind, two things. Connectivity is critical. The world is getting smaller. And second, data. And I think both Tony and Stephen touched on those things. To elaborate a little on connectivity, if I was to pick up the phone to call up an alumni in Australia now, I think I would get a response, and hopefully someone would pick up the phone and tell me what's going on. So if you think you would do that, please give me a thumbs up. If I was to call up someone else in the Asia Pacific region or somewhere else, what response would I get? And I think that's the challenge for us now, is to make sure that it's the MAE, both the program and the alumni, how do we make sure that the answer to that is unequivocal? And so that connectivity is critical. We need to work across countries and across professions that serve health. The second piece around data is there's huge, and I'm glad this is coming out strongly, we need multi-source data to inform any public health action. We need access, and something that I work on day to day here in WHO is access and benefit sharing, and the idea of equity through access and benefit sharing. So working with, and I work for a lawyer. I always thought lawyers focus on contracts. My lawyer focuses on policy, global public health policy, to make the world a more equitable place. And so what does an epidemiologist do working under that framework? So again, these are the opportunities to connect, but also the data that can then serve discussions around access and benefits. Communication. WHO recently established a hub in Berlin and epidemics and pandemics. And it was the first time I came across the concept of data artistry, data visualization, of course, and the community engagement. And I come from, as Stephen said, you need people from all walks of life. I'm a psychologist by training prior to coming to the MAE. So you think of community engagement, risk communication, and the need for people from different disciplines to come into the program and again influence and enrich that group. So let me stop there to just repeat and say connections and optimizing data. Back to you.
Thanks very much, Gina. Some great questions there, and it's something I was thinking about this morning in relation to the MAE students who started in 2020 and the opportunity for that connectivity and being part of the MAE family and the work that we need to do around that so that you can ring up anybody from any of the MAE cohorts and have their thumbs up. So let's ask Kate if she's got, Kate Astridge, some comments.
Sure, thank you. Something that I've reflected upon today is over the past 30 years, but also moving forward, is the energy and the passion that is attracted to the MAE. It's certainly not a degree that is undertaken reluctantly. We see each of us maintain these connections and have that drive continuing forward and also contributing to future epidemiologists in the system. So I guess something I think about in the next 30 years is how do we retain that talent? So making sure we don't lose it, looking after each other. I think the last couple of years, 18 months, has proven to be incredibly challenging for a number of us in whatever role we sit in, supporting each other. And I think, setting up those networks that we already have, but focusing on that support moving forward. I think in the next 30 years, there's a whole lot of exciting things that are happening too, and this was already touched upon by the earlier panelists. The open data, the movement towards increased sharing. There was a recent intergovernmental agreement signed with data, and if you can't share it, why can't you share it? Increasing technologies, leveraging the tools that we are using now and embracing, because out of necessity. We heard about REDCap earlier, GIS mapping. There's all sorts of great technological tools coming in that we can pick up and run with future graduates. I certainly echo the One Health approach, the not just zoonotic spillovers, also the antimicrobial resistance, but working more collaboratively with those other sectors across all of healthcare. I'm finishing with just that communicating evidence. I work mostly in translation of evidence into public health actions, and improving the evaluation of our interventions is also something I'd be excited to see in the future. Thank you.
Excellent, thanks, Kate. And Natalie.
Hi. So I guess I should start that I'm not a traditional epidemiologist. I think the only outbreak I've ever worked on was in my MAE, even though we're in the middle of a global pandemic. So I guess mine is definitely not focused on, the outbreak investigations, but more the social epidemiology, and wanting to make sure that the work that you do is very consumer and community driven as well, and being able to incorporate that into our epidemiology practices. And I do a lot of health services research as well, so making sure the work that is being done is relevant to the health services that you're working with at. So for me, that's a lot of Aboriginal community controlled services, hospitals and secondary services. So asking them the questions to help support them, what they might need to be done, and use your epidemiology skills. And so getting that skill set from the MAE, I think, will keep the MAE relevant, and then that also supports that translation of evidence. The other thing is, I know a lot of people have discussed data, but I think supporting MAE students as field epidemiologists, but also as a stepping stone onto other areas of work, such as medical statistics, machine learning and data-driven approaches and postgraduate courses in that, so that you've got epidemiologists that have multiple skills that can support government organisations to do the work that is being technologically driven. The more access to data you have and big data, I think it's not just I don't feel like the MAE is supporting that sort of work and long-term goals for people, and that could be how the MAE is relevant is people within field epidemiology are becoming statistical epidemiologists. They've got the knowledge to do machine learning, but on the groundwork to see how that's going to be applicable to their future work and the work of governments around as well. So, yeah, that's what I have. Thanks.
Excellent. Thanks very much, Natalie. And last but not least, Caitlin.
Hi, everyone. I'd like to just, acknowledge and echo the comments of everyone who's spoken so far. It's kind of challenging being the last one. Everyone's got great ideas already. And this has already been touched on by Gina and Kate, but I think the thing I think is increasingly vital in the EPI toolkit is health communications. Through COVID, we've seen an infodemic, an overwhelming amount of information, anti-science rhetoric, and I think it's really key to be able to, as an epidemiologist, synthesize and communicate evidence to lay audiences. And I know that's always been a core part of the MAE program, but I think it's increasingly important to be able to have the skills to communicate risk and benefit, particularly explaining and acknowledging risk is a really important step to generating public trust. Also, how to engage on social media and things like that. We've got increasing roles in that space in the public domain. And as Gina said, data visualization is such an important tool to be able to communicate our findings as EPIs as well. And we have a lot to learn from our social science colleagues. So I'll leave it at that.
Excellent. Thanks, Caitlin. I've almost got this little sort of word cloud that I've been noting things down, but and Amy's put in the chat the identified need for field EPIs to have stronger communication and leadership skills, and that's certainly come through here. But One Health's clearly a big thing. Equity, so all those values being relevant. Diversity in the people that we take in, because they become the sort of diverse people that finish the program and go on to a whole lot of different workplaces. Data, and this huge, I think it's really interesting, this sort of really focus on the tools, like the understanding the apps and the machine learning and all of that stuff. I think that's maybe somewhere that we don't do that much yet, but somewhere to go. So open to the audience now. Some comments or questions to any of our panel, or other comments on the MAE staying relevant. Not quite sure how I'll manage this because I can't see everybody. Just yell out, perhaps.
Could I sort of start? It's very great talk, great discussion about One Health data optimization and things like that. So on the note from Gina, so I just wondered when, Gina, you mentioned optimizing data, do you see the point of sort of data integration possibly, or intelligence exchange? So when you talk about One Health, also my name is Reznur. I'm one of the MAE team member. Sorry, I didn't actually introduce myself. Yeah, so when we talk about One Health, do we see the point of data integration, for example, or intelligence exchange? Because human health providers are doing their bit, animal health providers doing their bit, environmentalists doing their bit. So everyone is doing their bit. So is there a way of integrating things? So the most sort of simplistic notion of One Health is probably to combine 3 health systems together. But in fact, that's the real hurdle. That's the big challenge. So, what would you see going forward? So here, climate change, AMR, these sort of things come into play. So, One Health to me is creating mutually benefiting outputs where everyone gets benefited. Moving to deeper understanding. So I see One Health as a way of integrating data system, avoiding duplicates in collecting data and integrating things. How do you see when you say optimizing data, how do you see that occurring going forward? Jim, thank you.
Gina, do you want to respond?
Sure, thank you. It's a great thoughts there. Thank you. I think data democratization is what we need. In other industries, well ahead of public health, you no longer see the idea of data being brought into servers of a public health unit, then being funneled up to a national system, to a global system. The idea is that one could access data from anywhere, anytime, and that there are principles around that there are data norms and standards, and that in that case, data democratization is what we should be striving for. So all that, when you, of course, talk about health, come issues of privacy and patient protection, etc. But this is where the next frontier is. And it's great because this is the thinking going on now here at WHO with talking to other industries. They look at us and say, oh, we've done that 10 years ago. And the systems exist. So why is public health lagging in this one? So that's, I think, democratization. The other thing I feel is the concept of One Health. We now have groups coming out and saying planetary health and what have you. And I just think it's time for us to move beyond that concept. The principles remain the same. By no means am I saying don't do the concepts of the interface work, but I think we're starting to get stuck in the rhetoric of One Health. And so really it's upon us to start thinking what the next phase of this looks like, because the principles remain the same, and the data need to come together from various sources. It's just that we need the narrative to shift so that people can continually evolve it and see opportunities. I think we're getting a little stale on that one. Over.
Can I add something on the data side of things?
Yep, go to it, Tony.
Yeah, very quickly. I think the idea of data democratization is excellent. There's another level in there, and that is just removing the central piece out of that. I'll give you an example. For contact tracing, currently all the data goes to a central source and then someone contacts you. We have the tools already to be able to communicate peer-to-peer. And if you were exposed, if you were a positive contact, to be able to immediately alert everyone you've been in contact without having to go through a central thing. There are tools like that being used elsewhere in the world, but we're stuck in this idea that everything has to go to a central point, get checked, sent out. And I think taking that democracy thing to another level is, with appropriate privacy controls, you can share data peer-to-peer without and have an immediate effect. People would immediately know in the case of COVID that they needed to get tested and isolate long before they've been contacted by the State Health Department. So I think taking that example, there's a lot of work to do and it's a whole paradigm shift.
So just related to that, Gabriella has put in the chat a question for the panel. Why is it that to date we haven't used technology optimally to support public health action, for example, contact tracing apps, or public health data communication, for example, COVID data dashboards? It seems that we're really lagging other industries, and it took a pandemic to kick us in the right direction, but there's a way to go. How can we harness technology innovation in public health and field epi?
Build it before you need it. You can't build it while you're trying to use it at the same time. And so it's up to us to say, right, we now need to build the tools we'll need for the next pandemic.
Yeah, I agree completely, Tony. And I mean, it's here in the ACT with others. And looking back now, we could see that Sydney just down the road was going to cause problems for us. But should we have been wearing masks and socially distancing and doing various other things before it came, rather than saying, oh, whoops, it's here, now we have to do these things? Like, could we have put it off for just a little bit longer? So we never do we? We wait until it happens and then we scurry. But we know the next pandemic's coming. So I agree with you completely. We should, and the MAE is a great way to start to be thinking about the way that we can harness technology innovation. So maybe we have to liaise a bit more with the IT guys and those people that make apps and things.
I think public health has been the poor cousin in the health framework for some time. Prevention is still not treated, given the weight it deserves, compared to emergency department ramping or elective surgery waiting lists. Hopefully the pandemic will change that. But the question about why don't we have these systems, I do think it's about how public health has been viewed, the fact that we've never had this type of global serious public health event. There have been smaller things, most of them occurring in other countries that didn't particularly bother us, or that we had minimal engagement with. We had the 2009 pandemic, and that may in some ways have even lulled us into a sense of false security, that we've had a flu pandemic, but we managed it okay. We don't need to do too much more about preparing for other pandemics. So I do think public health and prevention hopefully will get more traction following this pandemic. And I think really as public health leaders, we need to make sure that we convert that into improved systems.
But Stephen, we're 18 months more and more than that into this pandemic now. Do you see that public health has become elevated to a level even vaguely near emergency medicine? We see the infectious diseases physicians telling us about public health. We see the virologists telling us about public health, basic scientists, whatever, immunologists, anybody tells us about public health. Like, if it hasn't happened now, how is it going to happen?
I think that's certainly true, and I think it's a hard space to protect public health because everyone thinks they can do public health, and we, as you say, we've seen that. I think it certainly has risen to a more prominent position, but just coming back to Tony's point, saying, you can't build it as you're using it. I think we're still so enmeshed in the day-to-day case numbers and drama of the pandemic, which is absolutely perfectly reasonable. There does need to be some time where we can step back and think about what the gaps are and how we fill them. And I think that should be a public health responsibility. Hopefully, we won't open up and wind down from the pandemic and then immediately turn to, that EDs are ramping up and we've got to catch up on all of this elective surgery and forget about preparing for the next pandemic.
Thanks, Stephen. So Amy's put in the chat, accreditation of epidemiologists would help. Any views on that from our panel?
You go, Tony.
Oh, you go, Kate.
I'm just reflecting upon, it was only a couple of years ago that the majority of people you talk to about being an epidemiologist would look at you with a blank look and say, oh, you look after skin, do you? It's been in the public eye in the last couple of years what an epidemiologist is, and that it's quite new. And I think there's opportunity in crisis, but we're so resource stretched dealing with the current pandemic that how do we use this timing to our advantage? I don't know how. I think it's going to be something we need to focus on moving forward.
Thanks, Kate. Tony and then Gina.
I'm just going to say, TEFINET does have an accreditation system for programs. Australia is unique in that we get a degree, which is an accreditation. But yeah, I think there's still a lot of work to do in that regard. I'll leave it there.
Gina, did you have a comment?
Yes, thank you. I think the MAE has one thing in Australia that's unique to it. We are the only FETP in Australia. And in that sense, we've got a brand that we can protect, that we can covet, and that we can promote and use to our collective advantage. And in that sense, I think if I like the idea of the concept of evaluating, doing an after action review of how this has gone for us collectively, and to do it in a way that actually builds the advocacy around it. We have alumni who are going into positions that we never went into before. I mean, look at the Asia Pacific ambassador for public health. I can't remember Steph Williams' title exactly, but you see this developing in an emerging area of public health being acknowledged by other sectors and making sure that well-being is the business of everyone, the private sector, the public sector. And I think using that brand of FETP, the disease detectives, the conglomerate that we are, is the opportunity. And how do we then, as Kate just spoke earlier about opportunity, the opportunity is here to really make hay of our brand. Over.
Thanks, Jen. So Ben and then Bridget.
Just on the point of accreditation, TEFINET has raised in the last 12 months the possibility of developing some sort of global standard for FETP alumni, and how that would be proven, whether there would be ongoing training, all of that continuing education, but yeah, it's only at the very earliest stages of discussion at this point.
Thanks, Ben. Bridget.
Thanks, Robin. I just wanted to agree. I think taking a good, long, hard look at this pandemic and being able to look at what's worked or what's worked better in instances would be very useful. I think we have a history of doing pretty short-term lessons learned in that we do them after instances like in 2009, but we actually don't retain them. So we discussed them at the time, and I think we all learn from that. However, we don't take those learnings forward, and I think we've already, I'm not saying, that then there's always the relevance of the current situation changing as well. The other thing I also wanted to raise, maybe as a question, is keeping the MAE relevant requires, and in terms of all the topics brought up, and I think we would all agree that there's a lot of priorities there. But how do you actually support the program to remain relevant? So we're talking about having to review or look at, recruitment to the MAE, the review of curriculum in the MAE, the review of placements in the MAE. I think they're all parts of the program that need to change to remain relevant and on an ongoing basis. And obviously that comes, requires resources to do.
Thanks, Bridget. So this is just a little personal thing. When I have been listening to the government's targets for opening, so 70%, 80%, and there's a lot put on the Australian population. It's up to you, go and get vaccinated. And then the modelling is based on having optimal testing, tracing, isolation and quarantine. And I just draw a horrified breath and say, so when is the government going to provide the funding to build the workforce so that we can maintain high quality T2IQ? And it goes again to this resources question, Bridget. Like it's just not possible to maintain TTIQ unless there is actually money being put into building the FETP and all of the other people that support TTIQ. But I don't hear anybody actually talking about what the government might be providing in that space. I don't know, Russell, whether you've got any comments in that funding sort of support space.
Yeah, so I haven't got any really learned comments, but obviously very interested in the space, Robin. And the question for me is, how has the pandemic transformed both the public and private sector's approaches to understanding and valuing what field epidemiology might do for them, and secondly, be seeing it as a wise investment. Because irrespective of everything, we need them to invest at least in terms of providing places. You know, even if it's not a cash investment, there has to be more than, you know, the tacit sort of investment for coursework programs that people provide, and that's the lifeblood of the MAE, and it's what makes it special. So I think we've heard, on a very positive note today, some really interesting perspectives from people who have taken quite non-traditional approach placements and really made something significant of them. And I do think that in some ways epidemiology itself needs to expand its horizons because it is now being shown to be very relevant to the human condition in ways that perhaps we mightn't have imagined before. And perhaps there's a core knowledge, but there's a penumbra of sort of opportunities for the MAE program to exploit that haven't been exploited before in the sorts of partners and placements that might be obtained. Look, I'll stop there. They're not considered thoughts, but I think they're questions more than suggestions.
Thanks, Russell. Mark, you've got something to say?
Thanks, Robin. And I think I'd first of all like to acknowledge and thank the MAE program for my career, really. So thank you. And probably more so than that, the great people I've met who've followed in the nearly 30 years since I was there. I just wanted to back, I think, comments particularly that Stephen said, that Kate said, and that Robin, you alluded to. There's a few things that have occurred to me in the middle of COVID for so long. Firstly is the gradually increasing overconfidence in the public's understanding of being an epidemiologist out there. I think that it's great that people have engaged with the domain, but I think it's really important that good professional epidemiologists continue to call the shots when sometimes naive or wishful interpretations of the data come to the fore. There's a fair bit of that happening. And the other thing I'd just like to reflect on that, it kind of comes to the TTIQ question. And, you know, it's a very important concept, the Doherty model and the TTIQ bit in it. But there's also been an enormous faith that the IT solutions will necessarily save the day. And I think we shouldn't underestimate the importance of the basic human elements of shoe leather epidemiology. Because we know even in COVID that most of your bang for your bucks comes from chasing up those people in the inner circle, and that outer endless penumbra of distant contacts provides much less yield. So I think it's important, again, that the basics are conducted well and valued, and the resources are provided to enable them to flourish. I think there's a really interesting conversation or discussion that probably needs to play out over the coming months. As people begin, we hope, to value field epidemiology in general, public health, that we manage to somehow or another form a bridge to maybe our political masters to value the role of epidemiology and public health practice much more broadly, in fact, than even public health, than our kind of field epidemiology passion. So we can somehow or another place value in chronic disease prevention and the like, which has historically been under invested in. So I think that's a very important kind of area to somehow or another capture the public's imagination with what can be done with good public health principles and well-resourced public health sector in that domain. So a bit of a ramble, sorry, but thank you.
No, thanks very much, Mark. Just a couple of things in the chat box from Katrina Roper. There are 3 ways to become an epidemiologist: the long course, the short course, and the self-declared. We've seen plenty of that. And from Caroline, there will never be enough money. We need to think about how best to leverage and provide value for every dollar invested, which of course is correct. Ben.
Yeah, echoing Carolyn's point, I think we need to cozy up to the health economists' shudder but the best way to get money for prevention and public health is to show that actually every dollar spent saves, $5. So that work needs to be done soon to show the benefits of good public health work, and that's how you get future programs funded.
Yeah, thanks, Ben. And is that something like we presumably have in-house expertise on that? So is that something that would be attractive for funding applications, do you think? Like, how would that be funded?
I guess, can I jump in here? Because I guess
yeah,
this
off
is
you go, Natalie. Yeah.
Something that I was sort of alluding to in my comments is that if you know a health economist, you'll know that you literally cannot get hold of them because everybody is trying to get hold of a health economist. And so this is where I think field epidemiologists and epidemiologists need to upskill so that it's within epidemiology. So you've got it there. You're not relying on what is in Perth currently like 6 health economists that are all being utilised for various research projects, but building that capacity within epidemiologists for them, if they're interested, to become those health economists, machine learners, statisticians. So they've already got that background there already. And if there was to be investment, then making those programs, partially funded through the government, I don't know, to increase that capacity within the epidemiology workforce. Because we have statisticians, you can't get hold of statisticians, you can't get hold of health economists. So I think if, as a group of epidemiologists, need to be generating this themselves.
Yeah, and it goes again to the diversity thing. So maybe one of the other ways is actually having some health economists who might come on to the program so they pick up those skills. So doing them both ways.
Yeah.
So thanks, everybody. This has been fantastic conversation. I'm going to hand back to Ben, I think, as we're now at our time. Or Emma, am I handing back to? I'm not sure.
I don't remember.
Take it away, Ben.
I've shut my agenda while I was on this. Look, did we have anyone down for closing comments?
No, we don't. So perhaps we should have, but I guess, just reflecting on the day, look, I think this is been more than the MAE team have ever hoped for in terms of attendance, participation and engagement today. So we really like to sincerely thank everyone who presented today, and for reflecting on your MAE experience and also providing your thoughts about where we can go in the future. I think that's so important, and highlighted to me how important this network is and what a brains trust there is in terms of having ideas about directions for the future. Just thank you so much. That's all from me, and Ben, you might want to say a few last words as well, and perhaps Russell.
Yeah, absolutely echo that, Emma. I was very concerned how this would go online, but it's just been fabulous. I've really enjoyed it. Thank you so much for all your contributions. It's just wonderful and inspiring to be part of this network. Thank you.
Can I just finish by saying a big thank you to the people who've done, the MAE team who've done all the organisation. And I'm not in the MAE team anymore, so I don't know exactly, but my guess would be it's been Ben and Hayley and Dawood and Emma, and I'm not sure who else is actually in there, but this has been a huge amount of work to have to pivot to Zoom, as we all have to do. And the things that I've been able to tap into today have just been fantastic. So thank you for a really great MAE community, and for being in Australia, because it gives us some safety, some feeling of all the great work that you guys have been doing. So thank you very much to those guys.
Thanks so much, Robin. Also, Toby and his team have been the real powerhouses of getting this working and told us how to do it and made all the put all the videos together, and they've just been wonderful. And Laura has really made everything come together. The only reason I got anything done. So yeah, thank you so much.
And Russell, did you want to say some final words?
What I would love to say, Emma, firstly is thank you everyone for sharing the day and sharing your stories and your experience. And I'll just finish by saying, look, I'm so excited for the program going forward, mostly because of the quality of people and the quality of what's gone already. And you know, I do want to pursue the idea that came up in the discussion of pulling together a personal stories about the scholars and graduates over the time. I know there's what, a few hundred, but we should tell those stories, because that is a very compelling narrative, and it's a great reason why the program should flourish into the future, and it's a great reason to give us all confidence that it will.
Great. Thanks very much, Russell, and thanks everyone. Enjoy the rest of your day.